We are live now, doctor.
Thank you.
Dr. Ritu, can you share the presentation?
Yes, I'm doing so. I hope my screen is visible now, Dr. Lippy.
Visible, it's visible.
Yes. So good afternoon, everyone. I welcome you all to the yet another session of YOSI iROCK. We have
I think we lost network.
this is the last
Ritu, Dr. Ritu, I think we are losing our network,
and
right?
final semi-final round, third round, in which
So is the issue with my network or Dr. Lippy's network?
I think it's with Dr. Lippy.
Okay. It's all right. I'll go ahead with the introduction, keeping the constraint in our
hello, am I audible?
another session of YOSI. All four of us moderators. I'll quickly. Yes, you are now.
Good afternoon, everyone. I welcome you all to the another YOSI iROCK session. This is our last semi-final round.
I think we lost her. Let's have a boombox. Now that was a rocking introduction of this prelims and semi-final session of YOSI iROCK. Our team YOSI of 2024-26 tenure is headed by our governing council, and this is the extended list. Focuses on ICO, medical legal, JCs, and job portals. But one of it was an extended arm of YOSI iROCK, that is a pan-India resident combat of ophthalmic knowledge. This is the team that is led by our team leader, Dr. Dup, of hers, and Mishra, sir. We have had semi-finalists have been contesting in the semi-final session 1 and 2, and this is the last semi-final on live. YOSI iROCK is a junior resident combat ophthalmic combat, and the top 2 teams of each prelims have reached here. So the 7 finalist teams will compete against each other at the final YOSICon, which is being hosted by the YOSI 24-26 tenure. And all these finalists will also be awarded travel grants in the YOSICon. So be sure that you are all physically present from 5th to 7th September at Habitat Center, New Delhi. The round presentation named iLeague Creative Round Session, that is Pupils Got Talent, Guess the Clinical Condition titled Knowledge Nexus, and Grid Find, that is Words with War. So this is the brief outline. We have eminent judges with us, naming a few. First, Professor Dr. Usha Singh, ma'am, who is currently working in the Advanced Eye Center, PGI Chandigarh, and she's serving as the president of OPAI. She has completed her undergraduation from Jaipur Pondicherry and PG from PGI Chandigarh. Her areas of interest lie in oculoplastics and retinoblastoma, and her nature of work is of medical education, creating research and patient care facilities. She has had numerous index publications to her feather, and she also has served as past president of Chandigarh Ophthalmic Society, executive member of AIOS, and also OPAI active member since 1998. Next, we have Dr. Sri Purna Ghosh, ma'am. Thank you so much for joining in, ma'am. She is currently working as a clinical tutor in Neel Ratan Sarkar Medical College, Kolkata. Ma'am had a dream of completing a fellowship in oculoplastics from Sri Shankar Deva Netralaya, Guwahati, Assam, and she successfully completed it. She has also been conferred the FICO oculoplasty certificate from the AIOS. Ma'am has multiple publications to her name, has authored chapters in various books, and has also participated in state level and national level conferences as faculty and also guest faculty for PG teaching programs. Her dedication towards teaching and her passion for clinical work is something to reckon for. Next, Dr. Vatsalya. Hello, ma'am. Welcome aboard. She's currently working as consultant at the ASGI Hospitals, Jodhpur. She is a proud alumnus of RPC AIMS and completed her fellowship in ophthalmic plastic and reconstructive surgery from the Sri Shankar Deva Netralaya, Guwahati. Ma'am has also completed her PG diploma in clinical cosmetology and facial aesthetics from ILA CAD, Mumbai. Ma'am has authored chapters in atlases and also books that were published by Elsevier and Springer publications. She has delivered instruction courses at AIOC, OTSI, OPAI, and various other national platforms. She also secured a first position in YOSI session in 2021, has narrated an e-poster at the IOSS Seoul, South Korea. Last but not the least, we have Dr. Sahil Agrawal with us, another proud alumnus of AIMS, New Delhi. He's working as assistant professor at the same place. His areas of interest lie in eyelid disease and periocular aesthetics and has authored more than 60 PubMed index articles. He's also an active peer reviewer in PubMed journals and is serving as assistant editor at BMC Springer Nature and specialty editor IJOP and editor at IJCR plus DJ. Thank you, sir. And our team leader, Dr. Nupur ma'am, is behind all the success. Ma'am had completed long-term fellowship in comprehensive and oculoplasty from LBPI Hyderabad, and she's currently working as the consultant of anterior segment and oculoplasty at iCare Eye Hospital, PG Institute, Noida. Ma'am has keen interest in academics and teaching, and that is how we found out iROCK, the brainchild of hers. She's also a YOSI executive member of last tenure, 426 tenure, and managing the editor of Your Times. Next, we have Dr. Lipi Mittal with us. She's an executive member of YOSI, a team lead of Cataract Focus Group, editorial team YO Newsletter, and a team member of YOSI iROCK Fellowship Navigator as well. Ma'am has many accolades to her name. Naming a few such as YO Slides, Ophthalmic Wars at AIOC Kochi, etc. She has delivered many talks at regional, state, and national conferences and presented a webinar on how to excel in your residency as well. A chapter on in the Oculus Res Geste book, which was the chief editor of which is our GC member, Dr. Prasanna sir. She is also featured in AIOC Times. Next, that's me. I pursued my post-graduation KGMU Lucknow, and I've had many opportunities to present at national and international conferences. I'm also recipient of a few awards and a keen interest in academics and research. Dr. Samhita, she's a consultant presently in Netradhama Super Specialty Eye Hospital and has specialized in cataract, oculoplasty, pediatric ophthalmology, squint, and ocular trauma. She had completed her long-term fellowship in Sri Shankara Eye Hospital, Bangalore, and her oculoplasty from Sri Shankar Deva Netralaya, Guwahati. She has also won a Best Paper YOS in 2015 and Best Paper at iPaper and many publications in many journals. Dr. Priya Sisodia. She has completed her UG from People's Medical College Bhopal and her PG from Gujarat Medical College and has done her SRC from Shivpuri Medical College. Dr. Priya has completed her fellowship in cornea and refractive surgery from Sadhguru Netra Chikitshalaya in Chitrakoot, and she is currently working at Retina Specialty Hospital in. I'll welcome Dr. Priya to introduce the participants next. Dr. Priya.
Hello. So we have
Yes.
hello everyone. So we have 6 teams. So from the team 1 we have, ma'am, can you please share the slide?
Yes, yes.
So we have team Oculus Curatio from MM Joshi Eye Institute, Hubli. So we have captain here Dr. Saurabh Nivekar, Dr. Abhinav Joshi and Dr. Uttara Bhatt. Next.
Ma'am, can you join? This is first actually. Hello.
Ma'am,
Hello.
am I
Yeah,
audible?
Dr. Priya.
Yes, you are audible, team.
Okay.
Dr. Uttara. So second, we have team Gladiators. We have Captain Dr. Shreya Jain from Arvind Eye Hospital, Dr. P. Monica and Dr. Chirag Kalra. Team captain there.
Yes, ma'am, I'm there.
Okay. Third, we have team IQZs from AIMS Raipur. Team captain Dr. Mustafa Makra, Dr. Sanya Parak and Dr. B. Mohan Prasad. Team captain, you are there?
Yes, ma'am, we are here.
Yes. Okay. Next, we have team Vision from Sadhguru Netra Chikitsalaya Chitrakuts. Here we have team captain Dr. Sonali Savan, Dr. Sarvam Bansal and Dr. Dikshant Khatri. Sonali, you are there?
Yes, ma'am. Am I audible, ma'am?
Yes, you are audible. Okay. Next team we have Multifocal Warriors from JLN Medical College, Ajmer. We have team captain Dr. Ranu Sharma, Dr. Simran Khosla and Dr. Madhur Harsolia. Team captain, are you there?
Yes, ma'am, we are here.
Yes, we welcome you. Next we have team Illuminati from AFMC Pune. We have team captain Dr. Varsha Chauhan, Dr. Sharan HB, Dr. Mehak Agarwal. Team captain, you are there? Dr. Varsha?
Yes, ma'am. Yes, ma'am. We are here, ma'am.
To ma'am. We have Dr. Prasanna Venkatesh Raman sir. Sir, can you please have a few words about this?
Thank you. Thank you, Priya. Hope I am audible.
Yes, you are audible, sir.
A warm welcome to the judges of today, Dr. Usha ma'am, Dr. Vatsalya ma'am, Dr. Shri Purna ma'am, Ghosh, and a dear friend, Dr. Sahil sir as well. Thank you for taking your time and being here for this YOSI iROCK session on a Sunday afternoon. We really appreciate your time and thank you for helping us out with a very tough job, especially judging when it comes to iROCK. And to have a few words on YOSI iROCK, we wanted to start something for the young ophthalmologists on a national level platform, which was something we felt will give them a podium to showcase their skills, where they'll be connected on a pan-Indian level to compete with their peers, especially the residents, to share and combat their knowledge in a competitive manner. And this idea was a brainchild of Dr. Nupur, as well as Dr. Devakant, the president of YOSI. And there has been 8 episodes in the prelims for all the viewers who are watching this. And we have had 3 semifinals. I was lucky to be part of all the three semifinals. The quality and the standard is very, very nice. And I think the audience is here. You are going to see the thing for yourself. So a big shout out to the YOSI iROCK team, headed by Dr. Nupur, followed by Dr. Priya, Harshal, Ritu, Dr. Neelam, Dr. Mausmi, Dr. Ritika, Pranesh, Dr. Sameer Chaudhary, Dr. Arshi Lipi, and Bharat Mittal, Dr. Sahil, Dr. Roma, and Dr. Samita. So each one has taken a special interest in getting this aligned. And to the four moderators out there, Lipi, Priya, Ritu, and Samita here with us. So big all the best to the team Gladiators, team Illuminati, team Icuzards, team Multifocal Warriors, team Oculus, Curatio, and team Mission. Your names are all very innovative, and I've seen some of the films, and you guys are doing a fantastic job. With that, we would like to welcome you guys all with a warm welcome from behalf of GC and the whole team UC itself for having a wonderful next 2 hours of a wonderful semi-final, and we are looking forward to having the winners of it. It's going to be a tough job for the four judges, but we are looking forward to having the finalists, finalists of the three semi-finals at YOSICon, which is going to happen on September 5, 6, and 7. So do watch out for it, and if not registered, please do registered for YOSICon. And looking forward to having you all. All the best to all the to all the 6 teams that were contesting today. All the best. Back to Priya.
Thank you so much.
Thank you, sir.
I'll have to reshare my window again.
In the meantime, I hope all the teams are ready with their presentations.
I'll be moderating the first round here, and teams, you'll be scored on the basis of your clarity, your timing as well, and the presence of your mentors, which gives you a +5 bonus point. So we'll first move with the iLeague seminar, and we have the following rules of it. One member of the team is here, which is pre-decided, and the topics were allotted to them beforehand. They're going to present it within 5 minutes, and there'll be negative markings if they exceed that limit. The question answer session will be followed after the seminar for a 2-minute round, and the whole seminar will be scored out of 20. We have the following teams, and we'll go ahead by the order as presented here on the table. So first is Team Oculus Curatio presenting their seminar on retinoblastoma topic. So the representative from the team, can you please share your screen?
Yes, ma'am.
Acha. That's scary.
Ma'am, some other participant is sharing the screen, so I can't share my screen.
Try again. So with the option of multiple sharing at a time is off.
Yes, ma'am.
I've stopped sharing my screen
Yes.
now.
Ma'am, am I audible?
Yes, you are.
I'll start with my presentation, ma'am.
Yes.
Good afternoon, everyone, esteemed panel of judges. Today, our team Oculus Curatio is going to present on a condition which has a plethora of symptoms from red eye to white eye, that is retinoblastoma. So it is the most common primary intraocular malignancy in childhood, being the seventh most common childhood cancer. Mean age of presentation is 18 months and origin is the cone precursor cell. The RB1 gene is the most important gene which governs the retinoblastoma disease, which is a tumor suppressor gene present on chromosome 13q14 and a dominant gene, and the inheritance being autosomal dominant. So in 1971, Sir Alfred Knudsen proposed two-hit hypothesis, which states that for a tumor cell to be cancerous, it has to, both the alleles in the recessive gene has to undergo mutation for it to be presentable. Coming to the pathophysiology, the cells of origin are the cone precursor cells in the inner nuclear layer. Grossly, the tumor is seen as a chalky white foci of calcification, and histopathologically, flecks of intestinal rosettes are characteristic of retinoblastoma. Coming to the clinical features, leukocoria is the most common clinical feature, which is present in more than 50% of the patients, followed by strabismus, red eye, reduced vision, and proptosis, orbital cellulitis, and phthisis. If a patient presents early, it indicates a red sign and indicates macular involvement of the tumor. The growth patterns seen are endophytic, exophytic, diffuse infiltrating, and vitreous seeding. Coming to the investigation, the more first and foremost is the clinical examination and indirect ophthalmoscopy till the aura. Ultrasound shows a tumor, that is B scan shows a tumor with intraocular calcification, and also it can show presence of retinal detachment. MRI is done to see extraocular spread and cases like trilateral RB. OCT is done to detect any presence of tumor in the apparently normal eye, and biopsy is done after enucleation. So management depends. Major goal is survival of the patient, followed by globe salvage, and then followed by the vision. So classification is done on staging and grouping. Staging is based on the survival of the patient as the outcome, whereas grouping is based on eye salvage. Staging is based on International Retinoblastoma Staging System, which shows that after stage 3, there is less prognosis, and stage 4 indicates a systemic invasion of the disease. Coming to the various treatment modalities, we have first cryotherapy, which is targeted for small peripheral tumors, involves the triple freeze and thaw technique, and it involves principle of tissue infarction. Second is laser photocoagulation, involving small group A posterior tumors and tumors away from the disc or macula. It uses argon laser of 532 nanometers and coagulates the blood supply to the tumor. Third is the transpupillary thermotherapy, which is now more widely used for tumors up to 3 mm with no vitreous seeds and for local control of tumor. It has direct cytotoxic effect on the tumor and causes apoptosis of the cells. Intravitreal chemotherapy, the most common drug used is melphalan, and it is used in cases where there is vitreous seeding, and it is contraindicated in ciliary body invasion, total retinal detachment, complete PVD, and diffuse vitreous seeds. Intra-arterial chemotherapy is used in unilateral disease with group D and E. Now, we do usually catheterization through the femoral artery, and it achieves 10 times more higher concentration of the drug, and complications include neutropenia, stroke, and alopecia. Systemic chemotherapy is reserved for bilateral large tumors with recurrence and extraocular tumors. The regimen used is the VEC regimen. Radiotherapy is less commonly used now, in the treatment modalities are the plaque brachytherapy and external beam radiotherapy. Enucleation, it is used for unilateral RB with neovascular glaucoma and anterior segment infiltration. To avoid recurrence, we have to remove the optic nerve stump more than 15 mm and treat with adjuvant VEC regimen or radiotherapy. So most important is the genetic counseling. So we have to screen parents as well as siblings for any mutations, acquired or hereditary, so that we can prognosticate the patient and the siblings well. One of the recent advances done May 2025 was use of gamma knife radiotherapy in chemo-resistant tumor. This gamma knife radiotherapy is also used for choroidal melanoma. So we have to see and know the glow, and so that we can start with early, we can do early prognosis and management of retinoblastoma. Thank you.
Thank you, Team Oculus. You just finished on time.
Yes, ma'am.
We'll take comments from your mentor first. Dr. Farath is here from your
Yes,
team.
ma'am.
Dr. Farath?
Hello, good afternoon, everyone.
Hello.
Okay. So it was a very nice presentation, Uttara, very precisely and
ma'am.
explained very well. And I would really like to congratulate the UC members for this initiative. It's actually a very nicely planned thing for the residents so that they increase their knowledge, their orative skills and everything. So yeah, it is a very good presentation. Looking forward to many such presentations from residents. Very good, Uttara.
Thank you, ma'am.
Yeah.
Thank you, Dr. Farath.
Thank you, ma'am.
So let's begin the Q&A session. We'll start with Dr. Usha, ma'am.
Good afternoon, everybody.
Good
I'm very happy to be attending this program with all the youngsters, and I've seen the quality of presentation is very good. Regarding the presentation, it was very good. So I just want to ask, is there a fourth goal? What is the fourth goal of treatment? Am I allowed to ask questions?
Yes, ma'am.
Yes, ma'am, you are.
Ma'am,
You can grill
genetic
them.
counseling and screening of the parents as well as the siblings.
That's a part of the workup. So the fourth goal is to minimize all complications and side effects.
Yes.
Okay. Vision is you may salvage, may not salvage. And regarding the treatment part,
Yes.
you have to. It will be good if you can categorize it into a local and systemic. So systemic
Yes, ma'am.
chemotherapy is now the workhorse chemotherapy for all the groups of retinoblastoma. Okay, and then it is followed by the local therapy. So almost in India, at least, intraarterial chemotherapy is very costly. Not everybody would go for it. Group D and E is well said, but Group E, some of them would go for upfront enucleation. Okay, but yeah, conditions where the parents don't agree, then you could try that. But there's always a small risk of metastasis and intraarterial chemotherapy of Group EIs. Okay, and so chemotherapy so you have systemic chemotherapy IVC, which is a workhorse. So you almost give it
Yes.
to almost every patient.
Every patient. Yes.
Okay, unless that patient specifically asks for intraarterial, or there's an indication there. Group D, Group B. So that's one thing. So it's not just that it is cryo only. So cryo is one of the local therapy.
Local therapy.
Laser is a local therapy. Intraarterial is a kind of a local therapy.
Local therapy.
Okay. Then you have TTT, that's also a local therapy. But systemic chemotherapy is the main workhorse chemotherapy. So it has to be followed by local. So it's a very well said. And so the first goal is, of course, you've clarified the goals. To first is survival, then to save the globe, and then to save vision if possible, and to avoid complications of any treatment, because all these treatments, chemotherapy, they are associated with hearing loss, or they have, toxicity to the retina, and intravitreal injections are associated with a lot of toxicity. Sometimes it's more or less safe, but there are reports of vitreous hemorrhage, choroidal infarcts, sectoral atrophy, all those things. So very well done. Thank you.
Thank you, ma'am. Thank you, ma'am.
I request Dr. Sahil for his question. Sir, please unmute yourself.
Sir is not audible, ma'am.
Sir, you are not audible. No, sir.
Thank you, ma'am.
So maybe you can log in again. In the meantime, we will ask Dr. Shripurna ma'am for her question. Ma'am, please unmute yourself.
Am I audible?
Yes, ma'am.
Yes, ma'am.
First of all, I would like to congratulate. It was a very nice presentation, very concise and crisp.
Thank you, ma'am.
Covering retinoblastoma within 5 minutes is really a daunting task, I think so. So it was very nicely done. May I ask you a question regarding, do you have any idea about tri-radiated retinoblastoma?
Yes, ma'am. It is a finding on the MRI, usually bilateral RB with pineal gland tumor.
Pineal gland tumor, or it could be a suprasellar tumor in certain cases, or a quadrilateral one when it has a pineoblastoma as well as a suprasellar tumor. Okay.
Okay. Okay.
Yeah, and any role of biopsy in case of retinoblastoma?
Ma'am, on biopsy, we can see the pathognomonic homo right and flexor intestinal rosettes, and
Yeah,
also we can
that's
see the
that's after
invasion.
excision. That's only after you enucleate the right?
Yes, ma'am.
Yeah, but nowadays there's a certain term called liquid biopsy, where you can take the aqueous humor and you can check for the cell-free DNA inside the aqueous humor. So normally till date it was only the biopsy from the enucleotide, as it was contraindicated in normally healthy living eyes. But a small amount of aqueous humor is now being taken, though it's a very expensive procedure, can be taken and we can look for the cell-free DNA from it, right?
Okay.
Okay. Otherwise, it was really nice and very, very crisp presentation.
Thank you, ma'am. Thank you.
Well done.
Thank
Thank
you.
you
just
so
want
much.
Thank you, Sri Purnima ma'am.
I just want to clarify. Excuse me, can I speak?
Yes, ma'am.
So there is no role of biopsy for diagnosing retinoblastoma unless a condition is there where you're really, you can't decide whether it's retinoblastoma or some other condition. Okay, in that case, there is a proper technique of doing biopsy. Liquid biopsy is for advanced tumors where you want to prognosticate the case. It's used at that time. You want to know whether circulating cell-free DNA is there or not, and whether this patient is going to develop metastasis or not. So the role is in that. That's it.
Thank you,
Thank you.
ma'am. Thank you, ma'am.
Thank you, ma'am. Dr. Sahil, your comments, please. Dr. Vatsalya, we'll go ahead with you.
Good afternoon.
Hello.
Am I
Good
audible?
afternoon, ma'am. Yes, ma'am.
Yeah. So to begin with, that was a fantastic presentation. And like Shriparna ma'am said, you took a very uphill task of concising retinoblastoma in 5 minutes. Usha ma'am is a stalwart in the field of managing retinoblastoma in India. So I think she's covered all the major queries or what was relevant. I just have a suggestion to make that whenever in the presentation any data is being shown, it would be nice if you could also add the reference as to where are you quoting it from, right? So that's just about it. Otherwise, it was very well presented.
Thank you,
Congratulations.
ma'am. Thank you.
Thank you, ma'am. Dr. Sahil, sir. I wonder if I think he has had some lag from his end. Chalo. It's all right. We'll move ahead with the next team then. That's Team Gladiators.
Thank you, ma'am.
Thank you, Team Oculus. Team Gladiators.
Yes, ma'am. Ma'am, should I
Yes.
share?
Yeah. The seminar is Ectropion. And yes, you can go ahead with sharing
Ma'am,
your screen
somebody
now.
else is also sharing.
Yes, yes, you can do it now.
Ma'am, can you tell me when I'm visible and when the timer starts?
Yeah, definitely. Please share your screen and I'll start the timer after that.
Ma'am, is it visible,
Screen,
ma'am?
please. Visible, yes, Dr. Chirag.
Is it? Just a second, ma'am. Oh, sorry, ma'am. Is it now visible, ma'am?
Visible, yes. I'm going to start the timer now.
Okay,
Start.
ma'am. So I'll be presenting on the topic ectropion. These are our learning objectives. And I'll begin with the question, what subtype of ectropion does this patient have? So ectropion can be congenital or acquired. Acquired can be further divided into involutional, cicatricial, paralytic, and mechanical. So the image we saw was of a cicatricial ectropion, as we can see the scar here. Then we have a mechanical ectropion due to some long-standing chalazion or let's say any tumor or cyst which pulls the lid downwards can cause ectropion, and involutional in senile patients due to horizontal lid laxity or lower lid retractor dysfunction. So the patient may present with epiphora, irritation, redness, photophobia, or foreign body sensation, and there may be a history of lid trauma or facial palsy or prior lid surgery. So we begin our examination with the lids. So we see the position of puncta. So the direction of the punctum away from the globe is the earliest sign of medial lid ectropion. Conjunctival keratinization and hypertrophy may also be seen. Corneal changes secondary to exposure may be present. Signs of lid repair or scars should also be looked for. On further examination, pinch test is done to assess the lid laxity. If the lid can be pulled more than 6 mm away from the globe, the lid is lax. And for snapback test, I'll show you a video. If the downward traction is applied to the lower lid and then released, the lid should revert to its normal position without a blink. For medial canthal tendon laxity, which is now being shown on lateral traction, it should shift only up to 2 mm. And for lateral canthal tendon laxity also, it should move only up to 2 mm. For orbicularis function, lack of thalamus and reduced force of contraction on forced eyelid closure demonstrate orbicularis muscle weakness. We can grade it as grade 1 punctal eversion, grade 2 as eversion of sharp posterior lid margin, grade 3 as palpable conjunctival exposure, grade 4 as exposure of the fornix. These are the basic surgical principles which I'll be discussing in detail. So for involutional ectropion, we have management based on the pathophysiology. So for horizontal laxity, we do horizontal shortening according to the area of maximum laxity. We can do full thickness resection, horizontal shortening blepharoplasty, and lateral tarsal strip. For lower lid retractor weakness, we can do reattachment procedures like lazy T and excision of diamond of tarsoconjunctiva and retractor reattachment. So this is a image showing full thickness lid resection. As we can see, a pentagonal full thickness lid resection in the area of maximal lid laxity is done. This is Kunt-Zimnowski procedure. Here the excess skin is excised as a lateral triangle from blepharoplasty and the lid is shortened under the flap. So for lateral tarsal strip, I'll be showing you a video. In this video, as you can see, we make a horizontal skin incision at the lateral canthus. Then we cut the limb of lateral canthal tendon, then manufacture a new tendon from the lateral part of the tarsal plate, and then expose the periosteum over the lateral orbital rim. Pass each arm of a double arm suture into the periosteum. This leaves a loop of suture under which the strip of tarsal can be pulled. So pass one needle through the tarsal strip just medial to the loop of suture and one just lateral to the loop of suture. When the sutures are tightened now, the loop pulls the tarsal strip posterior to the orbital rim. Then we close the wounds. So for medial canthal resection, it is done for severe medial ectropion with marked laxity of medial canthal tendon and lazy T procedure for which the image is shown. It is done when there is horizontal lid laxity, but MCT is not lax. For mechanical ectropion, we have to excise the mass as vertical as possible, and it is important to avoid scar formation and skin shortening. Z-plasty done for cicatricial ectropion. In this procedure, 2 flaps of skin are transposed, which increases the length of skin in the line of scar contraction at the expense of shortening the skin at the right angles to it. Other surgeries for this include VY operation, and if it is severe, we can do a full thickness skin grafting. This is the algorithm for paralytic ectropion. For medial ones, we can do Lee medial canthoplasty and medial tarsorrhaphy, and for the lateral ones, we can do lateral canthal elevation and lateral tarsorrhaphy. For general laxity, we can do facial sling procedure or skin replacement. So this is a case study showing pre-op and post-op pictures after lateral tarsal strip procedure for involutional ectropion. So this is the basic idea of what we have to do for the patients. We can always have complications like undercorrection or overcorrection, which can be reoperated, and granuloma formation, which can be excised. There's always a risk of recurrence. And post-operatively, lubrication is important along with wound care instructions, and signs of infection should be monitored. So my take-home message would be early recognition and classification, according to which we tailor the surgery according to the etiology and engage the patient in post-op care. These are my references. Thank you.
Just on time, team Clariators. Well done. We have their mentor, Dr. Jay, with us. Yes, sir. Welcome.
Good afternoon. So, well presented, Dr. Chirag. It was very simple, crisp, and very engaging with all the photos and the videos. And most of the points, whatever you can cover in this short time, you have covered nicely.
Thank you.
All the best.
Thank you, Dr. J. Moving to the grilling session, Dr. Vatsalya. Let's go first with you.
Yeah, hello team. So it was a very concise presentation. You have mentioned mostly the surgical treatments for cicatricial ectropion. Are you
Yes, ma'am.
aware of anything, any injectable alternative that we can try prior, or any other management for early cicatrix formation?
Ma'am, first of all, medical management, we should always give lubrication to the patient. And lid taping along the lateral cancers superotemporally can be done. And as far as I recall, we can give a Botox injection maybe as injectable.
So in cases where in early cicatrix formation, there is documented evidence that we can also give injection fluorouracil in a combination with triamcinolone in order to loosen the subcutaneous region. So that's another technique that you can try. Of course, it's not always prevalently used, but it's also a technique that you can consider. So well done. Let the others take
Thank you,
over.
ma'am.
Yeah.
Thank you, ma'am. Dr. Usha, ma'am.
I think Dr. Vatsalya has asked the right questions, so we can go on, proceed to the next.
Dr. Sripurna, ma'am.
I just have one, that videos which you have shown, they are taken from the net, I suppose. It'll be
Yes, ma'am.
nice
I
if
put
you
the
can,
reference.
it would be nice if you can present your own videos.
Yes, ma'am. Yes, ma'am.
That'll be better. Thank you.
Yes, ma'am. Thank you, ma'am.
Thank you, ma'am. Dr. Sripurna, yes, ma'am. Please go ahead.
Yeah, it was a nice presentation. It was very nicely, intricately designed. Actually, mostly all the points are covered. I don't think so. Any further discussions? Questions are there to be asked. It's fine.
Yes, ma'am. Thank you, ma'am.
Thank you,
Dr.
ma'am.
Sahil?
Thank you, Dr. Chirag. That was a concise overall presentation.
Thank you
So,
so much.
besides that 5F2 and T that Dr. Vatsalya has said, we also had a paper on use of autologous fat graft in cicatricial ectropions, where it not only provides a mechanical way to treat it, also gives regeneration to the skin locally there. Also, could you tell me about what is the most common way of treating post facial nerve palsies when you have an ectropion laterally in patients with seventh nerve palsies where you have an ectropion? What is the most common thing that we tend to do in all such patients? And what are the other surgeries that
Sir,
are
we can
available
do
for?
a lateral
Yeah, please go ahead.
Sir, for lateral right.
For the lateral, right.
Hello, sir. Sir, am I audible?
Yeah, you're audible. You're audible.
Yes, sir. Sir, we can have lateral canthal elevation. We can do lateral tarsorrhaphy, or we can do an elevation of the lateral cancers.
Right.
We
And
can also put a suture if it is lax.
And if you have a generalized laxity throughout the lower lid, what becomes
we can do a
first?
facial sling. We can also do a cheek lift.
Right, a facial link does good. Thank you so much, Dr. Chirag.
Thank you, sir. Thank you so much.
Dr. Sahil, we needed a few inputs from the previous seminar.
Right. So I was
Team
asking.
Oculus
I was
Curatio
about
that
to
had
ask her
presented.
about. Right. So I was about
Yes,
to
yes,
ask her
sir.
how is the use of OCT? Am I audible?
Yes, you are audible. Team Oculus Curatio.
Right. Right. So Oculus Curatio, I was to ask you about the use of OCT that you mentioned for the other eye. I mean, how useful or how easy or what are the difficulties that you face using OCT for screening out the other eyes? You had mentioned in your slides, Team Oculus Curatio.
Dr. Uttara. Yes.
Ma'am, OCT is helpful in diagnosing any posterior pole tumor, its extent, and since it is usually used for the apparently normal eye to screen for bilateral retinoblastoma.
So don't you think using OCT in children could be difficult, a tough choice then? Asking them to fixate and get a OCT of the posterior pole there, of the other contralateral normal eye. Relate.
Yes, sir. We can, in younger children, we can go for examination under anesthesia.
So that itself is the choice. I mean,
Yes.
what does Dr. Usha ma'am have to say about the use of OCT in the in children in such cases, ma'am?
Yeah, so OCT is only, it's a luxury where some institutes have this OCT. Okay, so but the diagnosis of retinoblastoma is on clinical examination and indirect ophthalmoscopy, MRI, ultrasound, all these things. And
Right, ma'am.
OCT, the role of OCT is when you're giving the treatment and you want to monitor whether there's a resolution of fluid and if there's any activity in the course of follow-up. If you see some activity during the course of follow-up, OCT would be helpful, or you can even do OCT angiogram. You can do to see for any activity. So this is for monitoring of the treatment, not for diagnosing retinoblastoma as per se. So that is.
Right.
And I
Thank you so
think
much.
this evaluation under anesthesia was lacking, what I felt. So that could have been more emphasized more upon that.
Yes.
And OCT is not a substitute for indirect ophthalmoscopy or your clinical examination. This point should be emphasized.
Okay.
Yeah, thank you.
Thank you so much, ma'am.
Thank you, sir. Thank you, ma'am.
I'm pretty sure it's very insightful, not for the JRs or the PG residents, also for the moderators here. We'll move ahead with the third team, that's Team iQuizzards, and the topic allotted to them is entropion. You can share your screen.
Yes, ma'am. Ma'am, is my screen visible?
It is.
One second.
Start the timer once you put it on slideshow.
Yeah,
Yes,
ma'am, I'm ready.
good to go.
Good afternoon, everyone. So we team iQuizzards will be presenting on entropion. Entropion is inward rotation of eyelid margin, most commonly occurring in the lower lid. So before diving into the clinical entropion, I'd like to tell the pathophysiology of entropion. So to maintain the eyelid, the two forces acting on the eyelid, horizontal and the vertical forces. Horizontal forces are the by the medial canthal tendon and the lateral canthal tendon. And also orbicularis oculi also gives some role to horizontal force. Then vertical forces are the protractors and the retractors. Protractors are basically the pretarsal and preseptal orbicularis oculi. And retractors in the upper lid are the levator aponeurosis, superior tarsal muscle. And in lower lid, it's the capsulopalpebral fascia, inferior tarsal muscle. Is it visible? So overall, forces that elevate the eyelid is orbicularis muscle, the protractor.
Dr. Sanya, I'm sorry to interrupt, but please put it on slide share. Thank you.
And forces that depress the eyelid is the lower lid retractor and gravity. That turn the eyelid in is canthal tendon and orbicularis muscle, and that turn the eyelid out is the eyelid retractor, gravity, and the eyeball. Classification of entropion is congenital and acquired. Acquired can be senile, cicatricial, spastic, or marginal. Congenital is rare, caused by hypertrophy or improper insertion of the lower lid retractor. It can be classified into mild, moderate, and severe. Mild, we usually observe the patient. Moderate is by lubricating and protective measures like BCL. And severe surgery, which I'll be mentioning later. Then coming to approach to a case of entropion, patient will present to us with symptoms of foreign body sensation, lacrimation, ocular irritation, and photophobia. And will have signs of punctate epithelial erosion, pannus formation, conjunctival congestion, and eyelid laxity. Involution entropion can be due to either vertical eyelid laxity, horizontal eyelid laxity, or overriding of the preseptal over the pretarsal orbicularis oculi. Clinically, we can diagnose by the snapback test, lateral distraction test, medial distraction test, and the distraction test. Cicatricial entropion is basically caused by scarring of the posterior lamella leading to inward rotation of the eyelid margin. Can be due to chemical burns, trachoma, or systemic condition in Stevens-Johnson's, or post-operatively in facile and severed surgery, or due to anophthalmic socket. Now, spastic entropion, it's a temporary inward rotation of eyelid margin caused by orbicularis muscle spasm. It's a vicious cycle. There's inward rolling of the eyelid margin, corneal irritation, which increases ocular muscle spasm. can be due to blepharospasm, chronic inflammation of either conjunctivitis, keratitis, postoperative spasm, or ocular pain. Management of all types of entropion. So first is conservative management by lubricating eye drops of BCL over adhesive taping of lower lid. Surgical, first is lateral tarsal strip done for mainly involutional or cicatricial. It corrects the horizontal laxity and is durable. Then coming to quicker diverting suture, it's a simple full thickness lid suture done for involutional entropion. Kuhn-Siemann procedure, there's a lateral full resection of full thickness wedge resection in the lateral eyelid. Jones quicker procedure can be done. It's done for mainly lower lid retractor disinsertion in involutional entropion. It corrects the retractor disinsertion. These procedure is the involution is done in horizontal eyelid laxity, correcting the involutional entropion. Then coming to anterior lamellar repositioning can be done with or without the lid split. It repositions the anterior lamellar skin and orbicularis, addresses lash corneal touch without extensive lid shortening. However, we can also do an anterior lamellar resection in severe cases, resecting the whole of the anterior lamella. Then another for spastic entropion temporary relief, we can do a botulinum toxin injection. It is quick, non-surgical. HOTS procedure can be done in congenital entropion. Simple, effective, and these are my references. And this is a patient of ours who underwent lateral tarsal strip surgery. Thank you.
Thank you, Team Ike Wizards. Well within time. We have their mentor, Dr. Q, with us. So please, any inputs?
Congratulations, Young Ophthalmological Society of India. It is very well presented by Sania, and most of the topics she has covered. And it is a great platform to connect young ophthalmologists, and best wishes to all. Thank you.
Thank you so much, sir. Dr. Sri Purna, ma'am, let's begin the viva from you. Dr. Sri Purna, ma'am.
Am I audible now?
Yes, you are, ma'am.
Yeah. I think, it was well presented. It was actually all the points were mostly covered, except for one thing. Did you? I think you missed out on tarsal fracture. It is one of the procedures which are normally. This is normally done for upper lid entropion. So maybe you could add that. Otherwise, then everything was more or less fine. Thank you.
Thank you, ma'am. Dr. Sahil?
Great presentation, Dr. Sania. So I think you skipped quite a few points. I mean, could you tell us about whenever you speak about congenital entropion, what also comes into role is in epiblepharon as an entity differential diagnosis. So when to diagnose them, what are difference, and when do you treat either of them?
So epiblepharon is one of the first differential diagnosis of entropion. It usually corrects by itself. We don't treat it. We can also put in hyaluronic acid filler if it's in a severe epiblepharon.
Do you treat both? Do you treat all cases of epiblepharon?
No, sir. Mostly it's observation.
Vis-a-vis congenital entropion?
Sorry, sir. Hello.
And in which population do you commonly see cases with epiblepharon? Am I audible?
Sir, no, sir, I could not hear your question. I'm sorry.
Right. What I was asking was, in which set of faces do you tend to see lower lid epiblepharon more commonly?
Asian.
Right. I mean, also, you forgot to mention about the signs for lower lid retracted dehiscence. That's again a very important entity when you speak about senile entropion. So maybe you can include those points in your next presentation. Thank you so much.
Thank you, Sahil sir. Usha ma'am.
I feel 5 minutes is too less to cover up the entire topic, and I think she's just put together everything on a slide, 2-3 slides. And it's also difficult for everybody to grasp also, especially the youngsters, those who are not used to or experienced. So I feel I just a suggestion, if you could just focus your presentation and discussion on some particular point, highlighting some, because a case is quite big and you can't discuss the entire case. Okay, some aspect, for example, retinoblastoma is a huge topic. Okay, you can talk either treatment or the genetics, or you can complications, side effects, you can talk anything. So the only thing I just want to ask the presenter, at what level in that Kunchumnowski procedure or the lateral canthal tightening procedure which you do, where do you anchor the lateral canthus? At what height, vertical height will you anchor it? Because the last slide which I saw, it looked a bit on the lower side.
2 mm above the middle.
Now, what is the clinical guide on the table? How do you assess where are you going to put it, the suture? Because if you don't know this part, then sometimes you'll have the, dystopia, lateral canthus dystopia would be there. So this is an important point. The last slide which I showed, there was an oblique view, So that told me that probably this needs to be looked into.
1 mm above the middle canthus, ma'am.
Anyone
I'm asking about the anatomical landmark there.
So maybe you could look up now. I think everybody
Ma'am,
is going to...
on the Whitnell tubercle.
No. Whitnell tubercle you can't see, but there's something which you can see, and then you can guide your needle, at what level you're going to. Can you see the pupil?
Yes, ma'am.
So it's related to that. So you just go through this, right? So then you will not have that lateral canthus dystopia, It has to go at the level of the pupil, the center of the pupil. Otherwise, it looks odd, Okay.
Thank you, ma'am.
Thank you, ma'am. The young minds will appreciate your snippets once they grow up to become oculoplastic surgeons. Next in line, we have vision, and the topic allotted to them is congenital ptosis. So, Team Vision, you can share your screen.
Yes, ma'am.
Put that on slideshow. Yes, your timer is started.
Are my slides visible, ma'am?
Yes, they are.
Good afternoon, everyone. I'm Dr. Sonali from Team Vision, and I'll be presenting congenital ptosis. So congenital ptosis is a condition in which there is an abnormal drooping of the upper eyelid, which can occur since birth or within first year of life. So it can be classified into simple ptosis and complex ptosis. So simple ptosis, in which there is levator dysfunction, but there is no other associated ocular abnormalities. And there is a complex ptosis in which there is other associated conditions like blepharophimosis syndrome, Horner syndrome, or myasthenia gravis. So coming to relevant anatomy, so there are three major muscles which contribute to the upper eyelid elevation. These are levator muscle, Muller's muscle, and frontalis muscle. Coming to evaluation of a case of ptosis, so detailed history is a cornerstone in evaluating congenital ptosis. So we have to start with the age of onset. The ptosis is present since birth or developed later in life. We have to see the laterality, if it is unilateral or bilateral, or if it is progressive in nature, or have a diurnal variation, to ask for any history of prior trauma or surgery,
for any associated systemic symptoms like dysphagia, dysphonia, or any history of any medication usage. Coming to family history, it's a vital part of evaluating congenital ptosis, especially in case of blepharophimosis syndrome, as it's an autosomal dominant condition, and these pictures are also showing the same. Old photographs can be of extremely useful in confirming whether ptosis was present since birth or later in life, and it also tells us if the ptosis is stable or progressive in nature. Examination of a ptosis patient begins the moment they enter the room. So we have to look for the head posture. Patients with significant ptosis presents with chin up position, and we have to check for the brow position, and especially in the cases of frontalis overaction. As shown here, facial asymmetry due to compensatory mechanisms, and we have to check for ocular motility to rule out any associated superior rectus weakness and oculomotor nerve involvement. To look for visual acuity to rule out amblyopia, and pupillary examination is must to, especially in cases of Horner syndromes and third nerve palsy. Lid crease is usually weak or absent in case of simple congenital ptosis, and it is elevated in aponeurotic ptosis. This image is showing a lid lag on down gaze, which is a classic sign in congenital ptosis. This is a Marcus-Gunn jaw winking phenomena. It's a type of abnormal synkinesis where the eyelid moves involuntarily with the jaw motion, such as chewing or sucking. Coming to ptosis measurements, so margin reflex distance 1 or MRD1 is the distance from the central pupillary reflex to the upper eyelid margin with the eye in primary gaze. MRD2 is the distance between the central pupillary reflex and the lower lid margin, and palpebral fissure height is the distance between the upper lid margin and the lower lid margin in the widest area. Then there is a margin limbal distance, which is the distance between the middle of the upper lid margin to the 6 o'clock limbus in the extreme up gaze, and a margin crease distance, which is the distance from the central eyelid margin to the lid crease. Then we can grade the ptosis. Ptosis is said to be as mild when there is a droop of 2 mm or less. It is said to be as moderate when the droop is of 3 mm, and it is severe when it is 4 mm or more. Coming to assessment of levator function, so this is the Burke's method in which we put thumb on the eyebrow in order to negate the frontalis action, and then we ask the patient to look from down gaze to up gaze, and the lid excursion is measured. In first year of life, mainly ellipse test is done, in which the upper eyelid of the child is everted as the child looks down. If the levator action is good, it will evert on its own. We can do a cover and cover test and Herring's test. Bell's phenomena is done to check for if it's a normal defense reflex of the eye, wherein on closing the eyelids, the eye moves upwards and outwards. We have to check for corneal sensations, leg of Thelmos, Schirmer test, and eye spec test. Coming to management of the congenital ptosis, so it depends upon the severity of the ptosis, risk of amblyopia, and the levator function. So when to operate? So early surgery is indicated if the visual axis is blocked, like if there is a risk of any amblyopia, and a delayed surgery is done if there is a mild ptosis and with no amblyopia risk. So surgical planning is based upon the levator function. Like if there is a good levator function of more than 4 mm, so we can do a levator resection as shown in this diagram. And if there is a poor levator function like less than 4 mm, we can do a frontalis sling surgery. For blepharophimosis syndrome, two-stage procedure can be done. In the first stage, we can do a VY plasty with transnasal wiring, and in the second stage, we can do the frontalis flap surgery. For Marcus-Gunn ptosis, we can do levator resection plus sling surgery, and for MEDs with poor Bell's phenomena, we have to avoid aggressive elevation that has to be taken care of. So to summarize, the history and clinical signs guide us, the levator function dictates our surgery, and timely intervention transforms our outcomes. Thank you.
Thank you, Team Vision. You have respected the time limits as well. Your mentor, Dr. Farheen, is she with us here?
Yes, am I audible?
Any words of encouragement?
Yeah.
Yes, you are, ma'am.
Good afternoon, everyone. I'm happy to be here as a mentor. Many congratulations to all the students for reaching this stage. It's a great achievement. And YOSI is a fantastic platform that gives residents and fellows the chance to learn, grow, and connect at national level. And it's inspiring to see young minds getting this kind of exposure in so early in their careers. All the three of them have worked really hard, and I'm proud of them and wishing them and all the teams very best. Keep learning and make most of this journey.
Thank you so much, ma'am. So we'll go ahead with the Viva YOSI. Dr. Sahil, let's start with you.
That was a concise presentation, I would say, Team Vision. You used the maximum of those 5 minutes available. to discuss this very long topic of congenital ectropion. So as you said, photography is again very important. It's the most important tool that we have as an oculoplastic surgeon. So I mean that's very mandatory. Could you tell me why is there a lid-lag in cases of congenital ectropion? So the LPS is what is non-functional, and the work of LPS is to lift the lid. So why do the lid lags when it goes in the down gaze? Why does it lag the globe in down gaze?
Sir, basically in congenital ptosis, the levator muscle is dystrophic. So whenever the patient looks down, so LPS muscle is not able to contract or relax. Basically, it's not able to relax properly. So whenever the patient looks down, the lid remains in the upper
Right.
position.
Neither does it contract nor does it relax. A levator plus sing in Marcus-Gunn joining phenomena. So what is the standard of choice and what is practically possible that we tend to do in
Sorry, sir,
cases
can
with
you repeat?
Marcus-Gunn joining phenomena?
Sir, please can you repeat the
So
question?
in cases with Marcus-Gunn joining phenomena, what is the standard of choice that is to be used? However, because of the practicality aspects, we tend to do something else.
Sir, if there's a significant amount of like if the patient is having problems with the thing, then we can do levator resection along with sling surgery, frontalis sling surgery.
Is it a bilateral sling that is done, or a unilateral sling, or a bilateral resection, or a unilateral resection?
So mainly bilateral sling surgery can be done because
But practically, patients do not tend to allow you to use the other eye. So most of the times, you end up doing a levator resection and an open sling of the same side. Thank you so much.
Thank you, sir.
Sir, Dr. Usha ma'am.
Regarding the Marcus-Gunn, I think a lot of difference of opinion is there. Each one has their thing. So what is recommended to, just for the sake of symmetry, you do bilateral excision. So I think towards the end when she was speaking, she said resection, bilateral resection. But we understand that she's trying to say by LPS excision followed by bilateral frontalis sling surgery. Correct?
Yes, ma'am.
Okay. But practically, if we are not convinced whether we want to touch the normal eye, we will not be able to convince the patient either. So most of the surgeons, oculoplastic surgeons, they don't do bilateral surgery. They do only unilateral. They just do excision, and that too, not all Marcus-Gunn would require surgery. So Marcus-Gunn is also graded into mild, moderate, and severe.
Yes,
So that is also there. So if a mild ones, maybe you can just leave it. But if you're moderate, if you try to do a LPS resection, it gets worse. So moderate to severe, if it is very severe, then of course you have to go for excision with a sling surgery. So there is a difference of opinion on this. And another thing I wanted to ask, the way she presented was, I felt she was confusing between the congenital and the acquired. So she was going back. I'm not trying to criticize, but I'm just saying when the patient first comes, you just decide right in the beginning it is a congenital or acquired. Then your workup goes on accordingly. If it's a congenital, you start working up in the way a congenital ptosis is to be worked up. You don't go back to ICE test. You don't go back to dysphagia history. That you would have done right at the beginning. So first thing you classify when the patient comes, is it congenital, is it acquired? And then your workup proceeds. And then you don't keep shifting. Because workup in acquired is very different. You have to take a lot of consultations. You have to do a lot of tests. You have to have a neurology consultation for probably a neostigmate test and other things. You have to take family history. There would be family history of ptosis. So it's a different workup, kind of workup. Right?
Yes,
so
ma'am.
that's the only thing I just wanted to say. So clarity of thoughts has to be there. Then only you can proceed in that particular direction.
Yes.
That's all. But otherwise, you've done very well. You've covered up very nicely. You've shown a nice video on Marcus-Gunn, and very nice. Another thing is the superior ictus. Why is the superior ictus involved? Can you tell?
Ma'am, in levator palpatory muscles and superior rectus, they're embryologically related. They have got that's why they are in small.
So they take origin from the same embryonic
Same,
and
same embryonic in this one.
Okay, right. That's it. Thank you. Well done.
Thank you, ma'am.
Thank you, Usha ma'am. Dr. Sripurna.
Yeah, hello.
Yes,
The
ma'am.
presentation was nice, especially because it had a lot of photographs and flowcharts, less of written part. I would like to congratulate her on that. And I would like to second Usha ma'am regarding the fact that there has to be a clear decision regarding whether it's a congenital ptosis or a acquired ptosis. Because for congenital ptosis, again, we won't go for the certain tests which we need to go for an acquired ptosis. So once we clear and when we have a case and we are speaking about a case, maybe when in our PG exam we are having a case on congenital ptosis, we do not need to speak about the tests which are not required for that certain case. Like when we are having an adult ptosis, we will not again go for ellipse test. We won't speak about it. Speaking about ellipse test in an adult ptosis is like not having an idea as to what the test is and when it's being done, right?
Yes,
Other than that, I think so more or less it was very nicely presented.
Thank you, ma'am.
Welcome.
Thank you, ma'am. We move next to our penultimate seminar, Team Multifocal Warriors. They'll be presenting the seminar on the topic Bell's palsy. Team Multifocal Warriors. You can share your screen, please.
Good afternoon, everyone. Today I will be telling you about the Bell's palsy. First, let's talk about the facial nerve. Facial nerve starts in the form of sensory root and the motor root from the pons, and then it travels and then enters to the internal acoustic meatus, where it travels in the facial canal, where it gives off the branches, that is the greater petrosal nerve to the lacrimal gland, and then the nerve to the stapedius muscle, and then the caudate tympani nerve that carries the taste sensation from the anterior two-third of the tongue, and then it comes out through the stylomastoid foramen to supply the facial scalp muscles and the stylohyoid muscles. What's upper motor neuron palsy and what's lower motor neuron palsy? Any lesion above the facial nerve nucleus causes upper motor neuron and below it causes the lower motor neuron palsy. Element palsy is different from the upper motor neuron palsy in terms of that here the jaw jerk is normal, corneal reflex is absent, and the Bell's phenomena is present. Bell's palsy is an acute unilateral lower motor neuron palsy of the seventh nerve. It occurs in 10 to 40 years of the age group and affects both men and women equally. Any etiology that causes the inflammation of the facial nerve makes it edematous and hence compromises its blood supply, leading to the necrosis of the facial nerve and in the later stages, paralysis of the facial muscles. Generally, it's idiopathic, but it's strongly associated with the herpes simplex virus family, diabetes, and hypertension. Signs and symptoms include pain behind the ear, mastoid region, numbness, facial droop with the loss of nasolabial folds, loss of forehead horizontal creases, difficulty closing the eyelid, drooling of saliva, hyperacusis, and the loss of the taste sensations. Generally, the diagnosis is clinical, where the examination of the facial nerve is done by asking the patient to show the teeth, close eyes, frown, raise eyebrows, blowing out cheeks, lip pursing, etc. And investigations include nerve excitability test, electromyography, trigeminal blink reflex, and to rule out other causes, CT or MRI can be advised as well. Generally, the facial nerve function is graded on the basis of House-Breckman grading, where grade 1 is normal, grade 2 is mild dysfunction, where full eye closure can occur with a light effort, and grade 3 is moderate dysfunction with the obvious weakness and closure with a strong effort. Grade 4 is moderately severe dysfunction, where asymmetry is present at rest and incomplete eye closure is present. And grade 5 is severe dysfunction with the trace movements of the facial muscles, and grade 6 is total paralysis of the facial muscles. Differential diagnosis mainly composed of Ramsay-Hunt syndrome, leprosy, Guillain-Barré syndrome, diabetes, etc. Prognosis is very good. 80% recover within 2 to 12 weeks with the recovery of the taste sensations before the motor function. Bad prognostic signs include severe palsy at the time of presentation, advanced age, persistent hyperacusis, and the severe initial pain. and it can get complicated in the form of contracture of facial muscles, exposure keratopathy, synkinesis, jaw winking, crocodile tears, hemifacial spasms, and the chronic loss of taste sensation, ageusia. Treatment mainly comprise first line of the corticosteroids and the vitamin B complex, where prednisolone is given 60 to 80 milligram per day for 4 to 5 days and then gently taper over next 7 to 10 days. It is an anti-inflammatory, hence it causes decrease the swelling of the facial nerve, decrease pain, and also reduces the possibility of permanent paralysis. Pain management include using analgesics, nerve blocks, and the neuromodulation. In severe cases, some practitioners also prescribe antiviral drugs, but their use is still unproved. Eye care includes lubricating eye drops, wear protective goggles during the day, and patching at night. And physiotherapy plays a major role in it, where we do the electrotherapy, shortwave diathermy, low level laser therapy, thermotherapy, facial massage, mind therapy, kinesiotaping, acupuncture, biofeedback training, and also strengthening exercises, that is the Cabot procedure, where we ask the patient to look upward for the frontalis section. For corrugator superciliary muscle, we ask the patient to frown. For orbicularis oculi, we ask the patient to tightly close eyes. For iliac nasi muscle, we ask the patient to puff the nose. For orbicularis or oris muscle, we ask the patient to whistle. For the buccinator muscle, we ask the patient to puff the mouth and then move air from side to side. And from the levator muscle, and my take home message is that we should not panic with the sudden onset of the symptoms. Consult doctor at the earliest, full recovery is possible, and avoid the overuse of muscles in the early phase, and consult a physiotherapist at earliest. Thank you.
Thank you, Team Multifocal Warriors. Dr. Shripurna, ma'am. Go ahead with the Viva.
It was nicely presented, especially the exercises and the physiotherapy part, which is really important as we need to do it in front of patients and explain it to them what needs to be done, or often we can refer to a neurologist. You have clearly explained most of the parts which is important. One thing that I would like to ask is when will you always plan for a neurological opinion for any case of Bell's palsy?
Ma'am, at the earliest, when the patient comes to us, we have to prescribe the patient about the eye care, that is the lubricants, if there is significant leg of thalmos is present, and we have to send them to the neurologist at the earliest to rule out if there are what are the causes that are causing the Bell's palsy.
Yeah. You always need to rule out the fact there is any SOL or anything which is compressing on the nerve intracranially. So that needs to be done. So a neuroimaging is a must, especially when it is not improving with time. And so a neurologist's opinion must be taken in most of the cases. Thank you.
Yes. Thank you, ma'am.
Thank you, ma'am. Dr. Usha, ma'am.
Oh, yeah, this is the most exhaustive coverage on facial palsy. So I just want to ask, when the patient comes to you, and middle-aged patient or elderly patient, what investigations can you do before you refer to any specialist?
Ma'am, first of all, we have to go through the facial nerve examination, and also we have to look for if there is significant leg of thalmos is present, or there is significant drooping of the lower lid that's causing more of ectropion and tear related problems.
I assume that you've done a complete thorough examination, but any blood biochemistry or any history which would point towards something? A middle-aged to elderly patient, what is the first thing you should be asking? Or maybe, it depends on your setting where you are.
Ma'am, we will go towards blood counts. Ma'am, as most commonly it's strongly associated with the viruses, herpes simplex virus.
More common than that?
Ma'am, left.
See, first is you have to rule out trauma. Second is you have to rule out diabetes, hypertension. These are the, you have to take the history right at the beginning. That's the only thing I want to emphasize. You've done a fantastic job of covering the topic very exhaustively in 5 minutes. I really congratulate you. So that's it. Anyone else can.
Thank you, ma'am. Dr. Sahil, please go ahead.
Right. Dr. Simran, as ma'am very well said that you have used the maximum of the time and covered this exhaustive topic. So, what would you suggest to a patient who doesn't want a surgery but still has a poor corneal health, corneal exposure keratopathy? What minimum
Sir, we will ask the patient for the patching of the eye and use
intervention
of
that you can do
the,
in such cases?
yes, patching of the eye can be done. And also ask the patient that during the daytime they can
Sorry,
use the
I lost you.
goggles and. Sorry, sir, you are not audible. Last thing
Can you
that you
come?
have.
Dr.
I
Simran,
lost you. Can you
please,
just come
repeat
again?
your answer, Dr. Simran.
Sir, first of all, if the patient is not ready for the surgery, we can go for the taping of the eyes. Patching of the eyes.
Right. What is a minimal intervention, a temporary intervention that you can also do, which is not as large as the surgery is? A small injection
So
there. What injection?
temporary tarsorrhaphy can be done.
So in place of that, you can also always give a Botox injection. It might take a 2 or 3 days, couple of days of time, which could also be classically a reversible procedure, which could help the patient to plan out or you take time to decide on the surgery later there. And I probably missed out on your slides. I mean, did you discuss about the static surgeries versus the dynamic surgeries that we do for patient of palsies? I mean, when do you do when? What?
Sir, generally during the acute phase of the palsy, we go for the static treatment because it can prevent the synkinesis in the further period. And as the acute stage has passed, then we can go for the dynamic treatment for the facial nerve palsy.
Right. Great. Thank you so much, Dr. Simran.
Thank you, sir.
Thank you, Sahil, sir. Finally, the team Illuminati is on board to present the topic on management of eyelid trauma. You can go ahead and share your screen.
Yes, sir. Right, ma'am. We'll just share.
Yeah. Team multifocal, do we have your mentor, Dr. Sonal? I couldn't see her on the participant grid. Okay. Team Illuminati, please go ahead.
So we'll start with our today's topic, that is management of eyelid trauma. Eyelid trauma can be caused by blunt trauma like this. It can also be caused by sharp trauma or penetrating trauma, as seen in the recent Russia-Ukraine war by drone attacks, or as seen in the Operation Sindoor between India and Pakistan. Coming on to the eyelid anatomy in brief, we have various layers of eyelids, starting from the skin and the subcutaneous tissue to the striated muscle layer consisting of the orbicularis, then coming over to the orbital septum, the pre-aponeurotic orbital fat, the Mueller's muscle, tarsal plate, and the conjunctiva. Now, the main thing to keep in mind is that the eyelid is composed of the anterior lamella and the posterior lamella, which is separated by the gray line. The anterior lamella comprising of the skin and the orbicularis muscle, and the posterior lamella comprising of the tarsal plate and the conjunctiva with the meibomian gland orifices. So any polytrauma patient coming to us, we should not forget to start assessment from the basic ABC management, that is looking after the airway, breathing, circulation, and only then coming over to the repair of the globe and followed by the repair of the eyelid injuries. After that, we need to go forward and do a complete ophthalmological examination as shown. Now, Mohapatra et al. Has given a classification, that is the SPOT classification for eyelid trauma, which says the system for periocular trauma classification, which classifies the upper eyelid zone as zone 1, lower eyelid zone as zone 2, medial canthus being zone 3, lateral canthus being zone 4, and zone 5 showing a more or less multi-zone involvement. NCCT orbit is one of the major investigations which needs to be done in these injuries to rule out any orbital fracture or any bony fracture, and is equally important for medico-legal purposes. Now, the primary repair of the lid injuries, it needs to be done within 24 hours of the lid injury. The primary goals being achieving a stable eyelid margin, protection of the ocular surface, restoring the anatomy and function of the eyelid. We have around 6 primary wound management categories, which include the non-marginal lid defects. Now, the smaller defects or the simple defects can be simply closed with 6-0 nylon or Prolene sutures, while the deeper defects, they need to be closed in layers. While if we come over to the full thickness lid defects involving margin, these need to be assessed based on the size of the defect, which can be from small to large as shown, and need to be managed accordingly. There are also some anterior lamellar defects which need to be managed separately. Now, lid defects, full thickness lid defects, which are up to 50% of the lid length, they can be managed by vertical mattress sutures as shown, where we go ahead with the 5-5-3-3 rule. And we need to suture the wound in 3 layers, starting with the gray line and then 1-1 suture each on the anterior and the posterior lamella. This can also be achieved by lateral canthotomy and cantholysis, where the lateral canthal tendon is cut, and cantholysis can be achieved by splitting the superior and the inferior limb of the lateral canthal tendon. Whereas if we have defects of around 50 to 75% of the lid length, a tensile semicircular flap may be helpful, which helps us to suture the bigger defects up to 75% in length. But if the defect is even bigger than 75% of the lid margin, then we have something known as the Cutler-Beard bridge flap, which is a full thickness advancement flap from the lower lid as shown, and it's also known as a lid sharing procedure. Coming on to the anterior lamellar defects, which can be let heal by secondary intention or by granulation tissue. We can also use flaps or tissue grafts for this. Now the flaps, starting with, we can have the sliding flap, where the skin is taken, the edges are undermined, and the surrounding tissue is then interposed over the defect. Or a direct advancement flap, in which the skin laxity allows us to advance the flap and directly close the defect. Or an interpolation flap, in which a flap is taken from an adjacent area and then closed over the defect. Mucous membrane grafts from the lip and posterior auricular region can also be taken. Now, canthal injuries, they involve reconstructing the canthus, anchoring the tarsus to the periosteum of the lateral bone. Similarly is for the medial canthal defects, where we fix the medial tarsus to the periosteum. And finally, the canalicular lacerations, where we identify the torn ends of the microscope and suture them under high magnification and place monocanalicular and bicanalicular stents. Now, what do we need to do? At the general ophthalmologist level are the superficial lacerations, and some injuries need to be managed by the oculoplastic surgeon himself. Thank you.
Thank you, Dr. Mehak. You just had 1 second on your board. Finished well on time. We have your mentor, Dr. Vijay, with us. So, please.
Yes, ma'am.
Yeah. Good afternoon, everyone. So, first of all, thank you, Team YOSI and Team iROCK, for this wonderful initiative. It is actually truly inspiring to see so many young ophthalmologists who are coming together on this platform to showcase their innovative ideas and presentations. This is what I think that precisely the vision why YOSI was founded. Heartiest congratulations to all the presenters and my best wishes to all the teams. Thank you very much.
Thank you, sir.
Thank you, sir. Dr. Usha, ma'am, your comments,
So
please.
before we actually move on, hello, Dr. Vijay,
Yes,
sir.
ma'am.
Yeah. So I just want to tell all the audience and all our judges that Dr. Vijay Sharma sir was actually the founding president of YOSI, and we'll be forever grateful to sir, for creating this platform and opportunity for all of us. And thank you, sir.
Thank you
Thank you
very
so much. Thank you so much.
Thank you.
Yes, ma'am. Dr. Usha, ma'am.
Yeah, it's a very vast topic to cover in this short 5 minutes. So one point I wanted to ask, suppose you see a little bit of fat protruding from the upper lid. What would you think of?
Ma'am, if we see some fat protruding, it is mostly the pre-aponeurotic fat, and it signifies that there is some injury to the orbital septum, ma'am. So the elevator aponeurosis is basically injured, and that is how the fat behind it is protruding out, ma'am.
No, you said pre-aponeurotic. Or you want to say retroseptal?
Yes, ma'am. The retroseptal fat, ma'am.
So you have to, whenever you see a very innocuous looking wound with a fat prolapse, you have to know that the orbit has been breached.
Yes.
Something. So there could be a small foreign body going from that wound to, to the orbit. So some of these subtle things have to be kept in mind. So that's one point I just wanted to say.
Right, ma'am.
Thank you, ma'am. Dr. Sahil, your comments, please.
That was a great start that you had done, Team Illuminati, with the thoughtful integration of the global events regarding operations, and especially once you're coming from Armed Forces Medical College, you're trying to integrate not only just procedures but your presentation that global level. So I would just like to ask, what are the various steps that you use to identify the middle canalicular tears whenever you're repairing a middle canalicular tear? So what are the 3 or 4 important steps that you tend to follow to identify the distal cut end?
Yes, sir. So in these cases, sir, first of all, we need to find the cut ends, sir, under a high magnification, and then we need to suture them, sir. So first of all, we can also identify these by irrigation, sir, or by probing. We can find out the cut ends, and then we need to repair them, sir. And
Exactly. How do you tend to find out, even if you use a very high definition microscope, at times identifying those distal cut ends is very difficult. So there are certain techniques that you tend to use to identify the distal cut end.
so the fish mouthing of the punctum will indicate that there is a medial canalicular injury, sir. Then during probing, we might encounter a soft stop, sir, which might indicate the injury, sir. It might indicate that the canaliculus is damaged, sir. We can also use the dye test, sir, fluorescein dye test. It also indicate the site of the leakage, sir.
That is a very important tool that we tend to use. You tend to use very commonly to identify the distal end of the cut, because
Sir.
even if you probe up, you might not exactly end up in the same track as that of the proximal and distal cut ends. So fluorescent dye comes off a very much hand.
Right, sir.
Thank you so much.
Rogers, thank you, sir.
Thank you, sir. Shri Purna, ma'am, your comments.
Very nice presentation, very
Thank you.
concisely done. But you could have written a bit about the animal bite injuries, maybe a dog bite or something,
Right, ma'am.
and whether you need to suture it early, suture it late, how much of suture, when to give the immunoglobulin, and the ARV schedule and everything, because it is a very common form of injury, especially in children that we find nowadays. So a bit about that could have been a bit better on your part.
Right.
Otherwise, it was a nice presentation.
Thank you, ma'am.
Welcome.
Thank you, Dr. Shripurna. So we have finished an exhaustive and informative
ma'am.
session.
Excuse me, ma'am, Team Multifocal Warriors mentor has not been called.
I did ask you if she's present. Anyway, Dr. Sonal, if you're here with us.
Yes, ma'am.
Good afternoon, everyone. I'm Dr. Sonal.
Hello, ma'am.
Congratulations, all of you, and I feel honored to be standing here amongst the bright young minds in Indian ophthalmology. To all of you participating today, whether you win or not, remember, excellence isn't measured in trophies, but it is questions you ask and the knowledge you carry. I feel proud to be a mentor of my team, Jalen Ajmer, participating in semi-finals third session of YOSI iROCK. All the best to you, and thank you very much.
Thank you, Sonal, ma'am. You reiterated the very thing, the very spirit of your CIRO competition. So
Thank
that
you.
being said, all work and no play makes Jack a dull boy. So let's move to our second round. That's Pupils Got Talent. And I request Dr. Priya to moderate this session.
Thank you, Dr. Ritu ma'am. So I hope I am audible. So coming to the next round, People's Got Talent. So the rules of the round 2 is team member will collaborate to give a creative presentation in the form of reel, music, dance, etc. on a topic of interest. 20 marks for the reel, or their presentation, and the theme is oculoplasty. So can we have the presentation of team 1, oculus curatio?
Every year, thousands are injured in road traffic accidents. But hidden behind facial bruises, one critical injury often goes unnoticed: the orbital floor fracture. The orbital floor is the thin bone forming the bottom of your eye socket. A sudden blow to the face, like
Dr. Ritu
in
ma'am,
an
can you please
RTA, can
restart
break
it?
this bone, causing the eye to sink or muscles to get trapped. Unrestrained impacts with the dashboard, side collisions, or helmetless riding are some of the leading causes. The various symptoms include swelling, bruising, sunken eyes, double vision, and numbness. Sometimes there can also be traumatic nerve paralysis causing drooping of the eyelids and restriction of eye movements. These signs may be missed without proper evaluation. A CT scan or an X-ray is essential to diagnose the fracture and check for trapped eye muscles or herniated tissue. Minor fractures may heal with conservative care, but persistent double vision, large fractures, or muscle entrapment may require surgery. The various surgical options include titanium mesh, porous polyethylene, also called as Medpor, bone grafts, which can be autologous or alloplastic, and other materials like supramid or silicone sheaths. In this clip, we can see removal of the bony fragments and repairing the defect in the orbital floor by placing a bioresorbable implant. Hence, constant coordinated efforts between oculoplasty and oral maxillofacial surgeon help to bring out better outcomes and hence better rehabilitation of the patient. Orbital floor fractures can have long-term effects if missed. Always wear seat belts, helmets, and never ignore facial injuries after accidents. Early recognition saves vision. Thank you.
So it is very good video presentation. So to save the time, we solicit comment from each only one judges. So Dr. Usha ma'am, any comments from your side? Ma'am, are you there?
Oh, sorry. I'm having some network issue. The electricity is gone, so I could missed out some part of the video and all that. But yes, she is pointing towards seven nerve palsy and the flow fracture with herniation of tissues and all. Apart from that, I could not hear much, so I would ask Dr. Sahil to please comment on.
Dr. Sahil sir, any comment for the reel?
So do we also have a Q&A for this, or this is just the comment that we need to put in? Do we have?
It's only
No.
comments. It's only
No.
comments. Yeah.
Only comments.
It was a great presentation. I think you could also include orbital emphysema, which becomes a part and parcel of a fracture thing, and is a very important diagnostic indication that once you're sitting in a casualty setting, where you need to treat and advise the patients about the non-blowing of their noses when you suspect cases with fracture. Otherwise, it was a wholesome presentation. Thank you so much, team Ocular Ratio.
Thank you, sir. So can we have the video of team 2 gladiators?
I somehow can't seem to play it. Please let me know once it's on.
Yes, Ritu, we can see it now. Yeah, you can just play the button. Yeah.
A single falling book can start a story or a misunderstanding. Meet Arjun. He enjoys books more than people. Partly because books don't misread blinks. Raghav Mehra, years of experience, top of his class, the kind of resume that doesn't need a second glance.
So, we have everything we need. We'll consider you for this position.
But his application was rejected. Let's see why.
What was this? Very inappropriate.
What looked like a wink was just a spasm. What seemed like flirting was just a condition.
Let's hear from the oculoplasty surgeon for expert insights.
So all these spasms and involuntary twitchings of attractions happening in the eye are due to the underlying neurological conditions, and all these are treatable.
So we do MRI to rule out neurological conflicts. Treatment includes Botox injection, which is temporary, requires repeated follow-ups, definitive microvascular decompression, and gamma knife surgeries.
Indications of Botox treatment are hemifacial spasms, blepharospasm, and myokinia. Look into a small video of demonstration of the procedure.
This patient has spasms involving the orbicularis, zygomaticus, depressors, and mentalis. After cleaning the injection site, 2.5 ml of botulinum toxin is injected at the glabella, targeting the involved muscle. Lateral canthal injection is the most painful and reserved for the end. These are the targeted muscles.
So these abnormal movements, spasms, or tics are treatable.
Spasms are silent struggles, but with Botox, there is hope and healing.
It was very
A
good
single
video. So, Dr. Usha ma'am, any comments?
A very nice video of injection Botox for blepharospasm. Very nice.
Okay, thank you so much, ma'am. So we have team 3 eye quizzers. Can we have a presentation of that?
There were two friends, Alsi and Kalsi, but both of them developed watering in one of their eyes.
Off किया था on कैसे हो गया?
And then started gossip. Some told it was due to old age, while others advised putting Ayurvedic drops or even honey. Conscious Kalsi chose to visit a doctor and was evaluated for various causes of watering of eyes. Complete regurgitation of fluid through opposite punctum implied NLDO. नॉर्मली हमारी आंखों में आंसू बनकर आंसू की नली से नाक के रास्ते से बह जाते हैं, परंतु एज के साथ अथवा कुछ कारणों से आंसू साफ होने की नली में ब्लॉकेज आ जाता है, इससे आंसू बाहर बहते रहते हैं. Kalsi was convinced and underwent an uneventful TCR surgery in which a fresh new pathway was created through lacrimal sac opening into the nose. Patients can also undergo an endoscopic DCR where no facial scar is left.
परेशानी होती है अम्मा?
आंसू आते में आंसू आके ना सूजन हो जाती है.
She had developed lacrimal abscess, a complication of untreated chronic necrocystitis.
It was an informative video. So, Dr. Shripurna ma'am, any comments from your side for the video?
Yeah, it was a nice video, very informative, really, and it could be really used as a tool for patient awareness, I think so. It's a really nice video.
Thank you so much, ma'am.
Thank you.
So, can we have next video from the Team Vision?
I think Ritu, you can reshare your screen, just
Yes, I'm
unshare and
resharing it.
reshare it. Yeah. So yeah.
अरे वाह, देखो मुन्ना कितना प्यारा लग रहा है।
हाँ, पर देखो ना, इसकी आँख सफेद क्यों लग रही है?
हाँ, तुम सही कह रही हो, इसकी दाहिनी आंख में सफेदी तो लग रही है, बाईं में तो नहीं है।
डॉक्टर को दिखा लें क्या?
अरे डॉक्टर को क्या दिखाना, इसके लिए तो हमारे चमत्कारी बाबा के पास इसका टोटका जरूर होगा। ये लो, बाबा ने ये मुन्ना के लिए काला धागा दिया है और ये काजल दिया है और बोला है कि हमें काले कुत्ते को रोटी खिलानी होगी, जिससे मुन्ना की सफेदी काली हो जाएगी।
हमारे मुन्ना को तो वैसे ही सफेदी है, चलो ना डॉक्टर के पास दिखा लेते हैं।
हाँ, तुम सही कह रही हो, मुझे लगता है एक बार डॉक्टर को भी दिखा लेना चाहिए। नमस्कार डॉक्टर साहब।
नमस्ते, बताइए क्या तकलीफ है?
देखिए ना डॉक्टर साहब, हमारे मुन्ने की आँख में 1 महीने से सफेदी आ गई है।
अच्छा, हाँ, इसकी दाहिनी आंख में सफेदी है। इसका कारण जानने के लिए कुछ जांचें करनी पड़ेंगी।
ठीक है डॉक्टर साहब।
जांचों में पता चला है कि मुन्ना को रेटिनोब्लास्टोमा है।
ब्लास्ट? क्या हमारे मुन्ना की आँख फटने वाली है?
अरे नहीं, रेटिनोब्लास्टोमा आंखों के पर्दे से उत्पन्न होने वाला एक दुर्लभ लेकिन गंभीर कैंसर है, जो अधिकतर 5 वर्ष से कम उम्र के बच्चों में मिलता है।
डॉक्टर साहब, इसकी दादी को भी आंख में सफेदी आ गई थी, जिसका मोतियाबिंद का ऑपरेशन करने के बाद वो ठीक हो गई थी।
हर सफेद चीज मोतियाबिंद नहीं होती। रेटिनोब्लास्टोमा के लक्षणों में शामिल है आंखों में सफेदी आना, तिरछापन होना, आंख लाल पड़ना, सूजन आना, रोशनी कम होना। मुन्ना की दिक्कत आंखों के लेंस की नहीं, उसके आंख के पर्दे की है।
डॉक्टर साहब, क्या इसका इलाज संभव है?
हाँ, समय पर पहचान और इलाज से इस बीमारी को पूरी तरीके से ठीक किया जा सकता है। इलाज की विधियां बीमारी की गंभीरता पर निर्भर करती है, जैसे कीमोथेरेपी, क्रायोथेरेपी, लेजर, सर्जरी और रेडिएशन थेरेपी। समय पर अगर पहचान करा और इलाज सही हो गया तो अधिकतर मामलों में बच्चा सामान्य जीवन जी सकता है। बस नियमित फॉलोअप जरूरी है। अच्छा हुआ आप मुन्ना को सही समय पर ले आए, नहीं तो ये बीमारी गंभीर रूप भी ले सकती थी।
धन्यवाद डॉक्टर।
So it was very nice and informative, very good acting by my DNBs. So Dr. Sahil sir, any comments for this video? He's here.
Dr. Sahil, you're not audible. You need to unmute yourself. No, you're not.
No, he's not here, I guess.
Just unmute again. No, we still can't hear you. Riya, maybe we can take comment from the next judge and take from Dr. Sahil in the next video. Yeah.
So Dr. Usha ma'am, any comments for the video?
I think it's an excellent video for awareness, creating awareness. The only thing which I felt maybe they could add one more point on the ultrasound. Just because very rightly said that all white cataract, all white reflex is not cataract only. So if a child has white reflex, they should at least get an ultrasound done, just to rule out this rare cancer. Otherwise, this is an excellent video and it can be used for creating awareness. It's a very good, it could be made even slightly more thing, but I liked it very much. Thank you.
Thank you, ma'am. So from the team Multifocal Warriors, can we have video?
Yes.
No, I'm sharing it in a bit.
Can I ask a question? Well, which team was the previous team?
Team Vision, ma'am.
Okay, right. Okay. So team Quizard did not present, did they?
Yes, ma'am.
Yeah.
Botox? They did, ma'am. On the primary acquired NLDO, ma'am.
Oh, acquired NLDO. Right.
Ma'am, we'll share the YouTube link with you later. So then whatever you've missed out, you can just catch it up on that and give your marks accordingly. So,
Right.
yeah. Yes, ma'am.
And the gladiators, what did they present? I kind of...
Ma'am, our video was on Botox, the hemifacial spasm and blepharospasm.
That one you said is Quizzards.
No, ma'am.
Wizards was
NLDO.
NLDO, acquired NLDO.
The Kalsi Alsi one.
Right.
Yes, ma'am.
Okay, thank you. I got it.
Should I move ahead?
Yes.
लगता है ये मेरी गिरती पलकों के कारण और मेरी आंखें तो सीधा देखना ही भूल गई। चलो किसी ऑक्यूलोप्लास्टी स्पेशलिस्ट को दिखाते हैं।
Ritu, the video is not playing. You can only hear the audio.
No video, please. No video is playing.
Resharing it again, ma'am.
Yeah.
Now?
No, that previous screen is visible with just the icons. Just unshare your screen once completely. Yeah. Now share it again.
Just let me know or else I'll do it again.
Yeah. Now it's coming. I mean, just go to the slideshow mode. 1 second. Yeah. Now play. Yeah.
शादी क्यों नहीं हो रही है? लगता है ये मेरी गिरती पलकों के कारण है और मेरी आंखें तो सीधा देखना ही भूल गई हैं। चलो किसी ऑक्यूलोप्लास्टी स्पेशलिस्ट को दिखाते हैं।
नमस्ते डॉक्टर साहब, मेरी एक बेटी की तो पलक झुक गई है और एक बेटी के भेंगापन हो रहा है। बड़ी समस्या, दोनों की शादी नहीं हो पा रही है।
घबराइए नहीं, आप बिल्कुल सही जगह पर आए हैं। ऑक्यूलोप्लास्टी नेत्र विज्ञान की एक विशिष्ट शाखा है जो आंखों के चारों ओर की बनावट और सौंदर्य से संबंधित समस्याओं का इलाज करती है। टोसिस में जब ऊपरी पलक नीचे झुक जाती है तो हम सर्जरी के द्वारा उसे सही ऊंचाई पर लाते हैं, जिससे दृष्टि और रूप दोनों बेहतर होते हैं। स्क्विंट यानी आंखों का टेढ़ापन केवल कॉस्मेटिक नहीं बल्कि फंक्शनल सुधार के लिए भी ठीक किया जा सकता है।
डॉक्टर साहब, ये इसकी आंख को क्या हो गया लड़के की?
इस मरीज की आंख में ट्यूमर था जिसके कारण हमें इन्यूक्लिएशन करना पड़ा, यानी आंख को निकालना पड़ा। अब इसे एक कृत्रिम आंख लगाई गई है, दिखने में स्वाभाविक।
एक्सीडेंट हो गया, इनकी ऊपर की पूरी पलक कट गई है, देखिए।
इनकी पलक की सर्जरी तुरंत करनी होगी क्योंकि अगर टाके सही से नहीं लगाए गए तो पलक अंदर या बाहर की तरफ
नहीं डॉक्टर साहब, ऐसा कुछ नहीं है। एक बार हमारे जानकार का ऑपरेशन हुआ था, उसके बाद से उनके हर बार पानी ही आता रहता है।
अरे आप चिंता मत कीजिए, इसका इलाज भी संभव है। हम आंसू प्रणाली की सर्जरी भी करते हैं और लिपोसुक्शन भी कर सकते हैं। ऑक्यूलोप्लास्टी के अंतर्गत पलकों की सर्जरी, आंसू की नली की समस्याएं, ट्यूमर, बोटॉक्स, सौंदर्य सर्जरी, टोसिस, स्क्विंट, एक्सीडेंट में लगी चोट आदि सभी समस्याएं आती हैं। और आजकल आधुनिक तकनीकों की वजह से उपचार न केवल सुरक्षित है बल्कि परिणाम भी उत्कृष्ट होते हैं। सभी समस्याओं का समाधान संभव है, बस सही समय पर सही विशेषज्ञ से परामर्श लें।
So it was a very informative video. Dr. Sahil sir, any comments for the video? I guess Dr. Sahil.
I think Dr. Sahil is having trouble with his audio. You can ask comments from Dr. Sripurna ma'am. Yeah.
Dr. Sripurna ma'am, any comments for the same?
Yeah, the video was very nicely done. Most of the diseases that we oculoplasty surgeons encounter, most of the diseases were covered in the video. Nicely done.
Thank you so much, ma'am.
Let's take a quick look at a few important cases which we commonly encounter in our opthal OPD.
क्या हो गया? कब से बंद हो गई है?
ये 2 महीने
2 महीने से। कोई चोट लगा था?
नहीं कुछ नहीं।
शुगर है, बीपी है?
शुगर नहीं,
बीपी है?
देखिए आप खुलेगी क्या?
खुल सकती है माता जी, इसके लिए आपको एक सर्जरी
The eye surgeon will make an incision in the crease of the upper lid or inside. There are muscles responsible for raising the eyelid. The surgeon will tighten one of the muscles or reattach it to the upper lid using stitches or surgical adhesives.
1-2 महीने से मुझे आँख बहुत लाल हो रही है और बार-बार पानी आते जा रहा है। बहुत ही दिक्कत है।
पहले कुछ ऐसा हुआ था, कुछ चोट लगा या कोई तकलीफ?
हाँ, मैं जब सीढ़ियों से उतर रहा था, सीढ़ियों से फिसलने की लगी तो यहाँ पे चोट लगी थी और उसके लिए थोड़ा ये टाँगे भी लगा।
आपका ना ये जो नीचे वाला पलक है वो बाहर की साइड है, मतलब लिड जो है वो बाहर की तरफ है, वो चोट की वजह से हो गया होगा, तो अभी इसका ना सर्जरी हो सकता है।
हाय रमेश, लॉन्च टाइम। हाय, कैसे है? बहुत दिन हो गए। मैं तो इधर ही था, तुम नहीं दिख रहा था भाई।
एक बात बताइए, क्या चीज़ है तुम्हारे हाथ के ऊपर? बड़ा ही दिख रहा है।
हाँ यार, कई दिन से है, मेरा बीवी भी बोलते रहता है कुछ तो हुआ है।
तो इस तरह के मस्से को इग्नोर मत कीजिएगा। ये हो सकता है चमड़ी का कैंसर, जिसे हम बोलते हैं बेसल सेल कार्सिनोमा, जो कि मोस्टली चमड़ी की निचली परत का कैंसर होता है, और तुरंत ही कांटेक्ट करना है आपको अपने नियरेस्ट ऑक्यूलोप्लास्टी सर्जन।
इधर देखो बेटा, दिन में 4-5 बार लीजिए, ऐसे इधर से ये उंगली से
दोनों
हाँ दोनों।
ना सोचो ये सिर्फ सौंदर्य का काम,
ऑक्यूलोप्लास्टी है जीवन का नाम।
Humors our fears,
trauma our fears. Oculoplasty brings back the tears.
So it was a very good video. Dr. Usha ma'am, any comments for the same?
Yeah, excellent video. Just I felt there was a background, some noise or something. So some words were getting jumbled up, though they've made a lot of effort in presentation and creativity, and they've covered up almost all the conditions. That's it. Regarding the relevance, I feel BCCA, it would occur in elderly patients generally. So that's it.
Thank you so much, ma'am.
Yeah.
Over to you, Dr. Ritu ma'am.
Yes. So we've had wonderful 2 sessions here, and I extend my heartfelt gratitude to all the judges, our mentors as well, for their words of encouragement for their respective teams. And here are the certificates of appreciation, and you'll be given the same on your email as well. Dr. Usha ma'am, Dr. Sripurna ma'am, thank you. Dr. Vatsalya, she had to go, but yes, she'll join in a minute maybe. Dr. Sahil, thank you so much, sir. And it would be lovely if you stayed back, but we have crossed the deadline, I suppose. And if you have other commitments, we understand completely. Yes,
Can I
ma'am.
say a few words?
Definitely, ma'am.
I really enjoyed myself seeing all the youngsters presenting, making such great efforts and innovations and creativity to present their stuff. So I really enjoyed myself, and thank you all so much. And I think it's youngsters are doing very well, and definitely with little guidance, they can do even much, much better. And I look forward to all these budding oculoplastic surgeons.
Yes, ma'am.
Thank you so much. Thank you.
Likewise, ma'am. I'll request everyone to switch on their videos as well. Let's have a quick photograph, and Miss Manjula will help us with that. The teams are well versed that we need to put up the YOSI symbol here. YO.
Manjula, can you take the photo for us, please?
Sure, doctor.
Yeah. Is it done, Manjula?
Yes, doctor.
Thank you.
So
Great.
before we move on to the
Also-
next rounds and say a goodbye to our judges, so I would like to thank the judges for their valuable time with us. And also I would like to invite, a few closing comments from all of you. Dr. Usha ma'am has already, given us. So one by one, Lippy, if you could just invite all our judges to say a few words for the session. Yeah, over to you, Lippy.
Yes.
Dr. Usha ma'am, we would like to hear from you any feedbacks or closing comments for all of us.
I just felt the only thing I felt was that 5 minutes is too less for covering up the entire topic. So if the residents, if the youngsters, they can focus on one particular aspect. That's where your concentration goes. That's where you come up with the latest innovation. That's where, like maybe just for example, facial nerve palsy, a new technique or something they have done on with their own hands. So I feel covering up, this is like a textbook covering up the facial nerve palsy. These they can read at home, but if they can show something, it'll be better and cut down the focus area rather than the whole topic. That's what I felt. I feel it's too much for people to present and grasp in 5 minutes. That's what I felt.
Sure, ma'am. We'll take care of it from the next time. Dr. Sahil, sir.
Thank you.
Thank you,
So
ma'am.
am I audible? I'm
Yes,
so sorry
sir,
for
you
the
are
glitch that.
audible. Yes,
Right. So
sir.
I was amazed with all the presentations that happened in the video. You see, and to the with the mentors who have done a great job there. And as ma'am said, yes, 5 minutes becomes too small for a topic like an entropin, or doses. So the others be more specific to some topics. And so much thank you, team. Thank you, Dr. Noor.
Thank you, sir.
Thank you, sir. Dr. Shripurna, ma'am.
Yeah, I would like to extend my thanks to YOSI for having me on board. It was really great. I enjoyed the session. Both the sessions were great, very innovative, I must say. But what Usha ma'am has said, that each topic can be again subdivided into small topics for discussion, or maybe case presentation, maybe a specific case that they have seen in their OPD and they can present that. I think that will be very illuminating for everyone. Thank you.
Thank you so much, ma'am.
Thank you, ma'am.
So before we move on, I will take this opportunity on behalf of Team YOSI to invite all our judges for the second annual YOSICon at New Delhi on 5th of September. So from amongst this session, we'll be choosing 3 finalists. 4 have already been chosen from the previous semifinals, and we'll be having the grand finale of YOSI iROCK at the YOSICon. So it would be a pleasure for all of you to join us there, and also see for the team that you have marked, and mentor them further. So thank you, judges, once again. Over to you, Dr. Lipi, Dr. Ritu, and Dr. Priya.
Thank you, ma'am. Dr. Lipi, you shall be moderating the round 3. Please let me know if my screen is visible. Dr. Lipi?
Yeah.
Yes.
So we'll move. Yeah, am I audible?
Yes, you are, ma'am. Yes.
Oh, okay. Waiting for your, okay. The screen is not visible to me.
Lipi, the screen is visible. Yeah.
Okay. So this round is
Lipi, we are losing your audio. So till you correct your technical glitch, Kritu, can you go on with speaking over?
Yes.
Yeah.
Any guesses? So this is type your team number in the chat box. I hope everyone. iQuizzards is number 3. Team Vision is number 4. Multifocal Warriors is number 5, and Illuminati is number 6. You will be. Am I audible?
Yes, you are.
Lipi, your audio is cracking a lot.
Okay.
So I think let
Okay.
Dr. Ritu take over the audio part. You can just try
I'll just
logging in.
start again. So this is Okay.
Up, everyone. I'll be showing you a trial round here, and you are well versed with. After I finish up the question, you will type your number as presented here on the table, and we'll ask you to unmute and then only answer. Dr. Priya?
Yes, I'm ready.
I will need you on the chat box here. Hey, number one, this actor from Bollywood with a famous surname made his acting debut in 2012 with an action romance movie. Team.
Team 2, Gladiators.
Team 2, you can unmute yourself and answer.
Kapoor.
Yes, you are right. And this is how the questions will be. Well done. And this will fetch you a plus 20 because you answered it in hint number 1. So rub your fingers and let's go with the
So
fastest
hope
finger
no,
first.
no,
Your first
hope there
clinical
are no,
condition.
yeah, 1 second. Yeah, so hope there are no doubts regarding this round and we are good to proceed. Hope no teams have any, you need no clarifications. Yeah, okay, go ahead, please.
Yeah. Your first clinical condition is here. Guess the systemic disease. Retinal findings of linear dehiscence associated with metabolic bone disease.
So be very
We
careful.
have team.
Yeah.
Team
Team
2.
Gladiators.
Please unmute yourself and answer.
Paget's disease?
Can you repeat?
Paget's disease, is it?
Yes.
Yes, it's the correct answer.
Well,
So you get plus 20.
go ahead.
So I think we can move on to the next question.
Yes.
Flip, your audio is good now. You're good to go ahead. Yeah.
Okay. So this is an audience question. So audience, please be ready.
If you know the answer, you type I in the chat box. Yeah, over to you.
So identify the retinal pathology shown in the image. Is it VMA, VMT, ERM, or CME?
Ritu, who's keeping a tab on the timer?
Ma'am, it's Dr. Priya.
It's Shazia.
Dr.
Is it
Shazi.
option C,
Dr.
ERM?
Shazia.
Dr. Shazia can unmute herself.
Yeah, is it option C, ERM?
Yes,
Yes.
it's the correct answer. So we can move on to the next question. Teams, be ready for the next question. And your first hint is history of chronic eye rubbing or keratoconus.
It's Team 6, Illuminati.
Please unmute yourself.
It's vernal keratoconjunctivitis.
I'm sorry, you get minus 20 for this. We can move on to the next hint. Now, this hint is not applicable for the other teams. Please wait for the next hint. So the condition has dense white anterior subcapsular opacity. All the teams can answer, or so all the teams can attempt.
It's again, ma'am, Team 6, Illuminati.
Ma'am, is it atopic dermatitis? Shields cataract. That is Shields ulcers.
Yes, it's shield cataract. So congratulations, you get plus 15 for this. Moving on to the next question, which is an audience question. So audience, please prepare yourself for the next question. The anterior segment dysgenesis reflect embryonic abnormalities related to which cell line?
Is it neuroectoderm, mesoectoderm, neural crest, or surface ectoderm?
Dr. Tajia.
Option D, surface ectoderm.
No, it's the incorrect answer. The correct answer is neural crest. So teams, be ready again for the next question. And your third condition, the first hint is, guess the syndrome. Tyrosinase positive oculocutaneous albinism associated with autosomal dominant condition.
It's team 2 gladiators.
Please unmute and answer.
Ma'am, is it Waardenburg syndrome?
Yes, it's correct. So you get plus 20. Team 2 gets plus 20 for this question. We can move on to the next question. We can skip the other hints. So again, it's an audience question. A patient has short stature, aortic stenosis, and mental retardation. On examination, the discs are consistent with glaucoma. What is the most likely diagnosis? Peters anomaly, Rieger syndrome, ICE syndrome, or posterior embryotoxome? Come on, audience. This is an easy question.
It's Dr. Sajia. Can you please unmute yourself?
Option B, Rieger syndrome.
Yes, it's correct. Congratulations, Dr. Shazia. You have given two correct answers. So moving on to the last question for this round. Teams, prepare yourself. The fourth condition, and the first hint is, guess the syndrome. This is associated with type 2 and type 11 collagen disorder.
It's team 5 multifocal warriors.
Please unmute and answer.
Ma'am, Strickler syndrome.
Yes, it's correct. So team multifocal warriors get plus 20 for this question. Congratulations. So moving on. So before we move on to the next round, Dr. Priya or Dr. Ritu, can we have a score? Can we tell the score for this round?
Yes.
Yes, ma'am.
Teams 1, 3, and 4 fetched plus 20 in this round, and team 2 has a minus 5. Sorry, team 6. Sorry.
Team 2 has...
It's for the questions. I'm really sorry. The question 1, 3, and 4 were answered by team 2 and team 5 respectively. So team 2 has a 40, team 5 has a 20, and it's team 6 which has minus 5.
Yes.
I request Dr. Priya to take over the round 4.
Okay, so round 4 is wordsmith war grid. Can you share the screen? So the rules for round 4, each team will be projected with a grid of words on the slide. One player from each team will answer. Identify 6 ophthalmology related words in the grid, plus 1 for each correct answer, no negative marking, and each team will get 1 minute to identify. So let's start. So this is the trial round for fruits. So you have to tell 6 fruits name.
So any of the team can randomly, yeah,
Two,
can
you can
just.
unmute yourself. Just attempt at it for the
Banana,
fun.
apple, pineapple,
Yes.
strawberry,
Berry.
strawberry, mango. Kiwi apple. Bas.
Yes. Okay.
Yeah, so that's how the grid will look like. Ritu, can you move on to the next slide, please? Yeah. So this was just to give you an example. Okay, I hope it's clear to everybody. Over to you, Dr. Priya and Dr. Ritu. Yeah.
Yes. So for the team 1, Oculus, your time start.
Vitnal, eyelid, follicle, keratitis, fundus.
One more.
Keratitis panus.
Yes.
Good job.
Yes. Ma'am, can you please show the answer? Yes.
It's done. It's done. Yes.
14 seconds.
Yes.
Am I audible, ma'am?
Marks. 6 marks to the team.
Am I audible, ma'am?
Yes, you are audible. So next is for team gladiators. Your
Ma'am,
time starts now.
Voscius, Canthus, Limbus, Lattice, Acuity, Retina.
Yes.
I think 6 are done.
Yes. Very
Yes,
good.
6.
So we can give full marks to them. Team 2.
Ritu, can you show the answers, please?
Retina was not there. It was Clara.
Yeah.
Plus 5.
Yeah.
Yes.
Yes. They got one wrong. So it's plus 5.
Plus
It
5.
was
Yes.
Clara in place of Retina.
Yes.
I'm moving next.
Next is for team 3. Can you please change the slide, ma'am? iQuizzets. Time starts now.
iQuizzes, are you there?
Hudson, Marcus, Meiosis,
Yes.
Iritis,
2 more.
They gave 3 so far.
Marcus.
Time is up, Priya.
Yeah, time's up.
Yes. Ma'am, can you please show the answer slide?
So they gave 4 correct, 4 answers.
4.
Yes, 4.
Let's see.
Plus 4 to team 3. Next question, please, ma'am. So it's for team 4, vision. Your time starts now. Are you there?
Yes, ma'am. Ma'am, Snellen, Placido, Tonopen, Botox.
Yes.
Good.
Good. 2 more.
Dacryops.
Yes.
Snellen, okay. Hyaloid.
Yes, correct. So plus 6 to team 4.
Can you show the answers once, Ritu?
Yes, yes.
Yes, ma'am.
Okay.
Okay, yes, plus 6 to.
All right.
Next slide for the team multifocal warriors. Your time starts now. Are you there?
Ciliary,
Yes.
sclera,
Yes, yes.
Yes, yes, yes.
bipolar,
Yes. Yes.
Uvia.
Good.
Uvial.
Okay. Two more.
Lamina.
Yes.
Yeah, time.
We have 8 seconds.
Ciliary तो बोल दिया ना.
Yeah, time's up.
Sclera.
Time's up.
Ritu, can you show the answers first? Yeah.
Molar. They missed Molar and they
Plus
have
5
+5.
to team. Plus 5.
बाइपोलर तो पुरानी चल रहा है ना. ठीक है.
Yes. Team 6, Illuminati. Are you there? Your time starts now.
Yes, ma'am. Punctum, Caruncle, Wolfram, Foster, Ampulla,
Yes.
कैरानिकल
Caruncle हो गया.
Already done.
Yes, hurry up. You can do it.
Yes. Two more.
Just one.
Lenstar again. No.
Time.
यार भी वो
I think
Dr. Lippy.
Just 2 seconds. Yeah, time's up.
yeah,
Okay.
time's up. Ma'am, can you please show the answer sheet?
Yes, yes, yes.
हो गया सर वो
So they had 5.
Ampulla, Foster, Wolfram, Punctum, Caruncle. What is
5. Plus 5 to team.
Alport you missed. Yeah.
Okay.
So round 4 ends here with the team scoring +6 for team 1, +5 for team 2, +4 for team 3, +5 for team 5 and 6, and +6 for team 4.
Yes.
Dr. Lippy. Are you with us? This was a wonderful session. Dr. Lippy?
Yes.
Yeah.
So we have come to the end of the semifinals round. This was the last semifinal round, and all the teams have done really well. So in this round, 3 teams will be winner, but you guys are already winners because you have already cleared the prelims round. So all the 3, I congratulate to all the 6 teams. Thank you for your inputs. I hope you have also learned a lot from all these sessions. These are the I present certificates to each of you. Dr. Chirag Kalra,
Thank you, ma'am.
Dr. Dikshant, Dr. Madhur, Dr. Mehek, Dr. B. Mohan Prasad, Dr. P. Muhanta, Dr. Mustafa, Dr. Ranu Sharma, Dr. Sanya, Dr. Sarvam, Dr. Saurabh, Dr. Sharan, Dr. Shreya Jain, Dr.
Thank you,
Simran,
ma'am.
Dr. Sonali, Dr. Uttara Bhatt, Dr. Abhinav, Dr. Varsha. So it's the photo session time. I request all the participants to please switch on your video.
Manjula, can you take the screenshot for us, please?
We had a lot of connection lags, guys, but you all prepared well. We could see that in your seminar and all the rounds.
Yes.
So let's go with double yo.
Manjula, can you take the screenshot for us, please? Manjula, are you there?
We'll be stuck here for a while now. Manjula ji.
Manjula ji.
I'll
Ritu
take
can,
it. I'll take
yeah,
it.
Ritu, you can take it for us.
Yes. Say cheese, everyone. Or maybe just say YOSI.
YOSI.
Yes. Lovely photographs.
Thank you so much, everyone.
So we'll disclose the results at 8 p.m. tonight. Congratulations to all of the teams. And we look forward for your participation.
Thank you, ma'am.
In the upcoming YOSICon, all of you.
Thank
We'll
you,
meet
ma'am.
there at the YOSICon.
So
Thank
before
you,
we
ma'am.
end, I think this is the absolute last session of, the online session of the YOSI iROCK 2024-25. We started the session in September. No, we started in February. We rolled out the forms in September. So it's a little bittersweet moment, for the entire team. So we'll be seeing, hopefully, all of you, not just the winners at the YOSICon. And it's been great. I think from the entire iROCK team, it's been great, connecting and coordinating with all of you for these sessions. And I must congratulate all of you for showing up the courage to participate in this event, and I'm sure that I hope that all of you had as much fun as we had organizing it. And uh, we would love to hear from you, one by one, if you all can just say something uh, from all the teams, starting from team one, just, anything that, whatever comes to your mind. So,
Oculus Curatio,
anybody?
Gladiators, iQuizzers, Team 1, 2, 3.
Ma'am, I would like to say something.
Yeah, please.
Ma'am, we really enjoyed the sessions and especially interacting with you guys. You were very accommodative, and especially today morning when I called Ritu, ma'am, my video is lagging, and she made sure that I was at rest and I was fine.
Thank you.
Thank you, ma'am.
With every
Actually,
session
I
of
want
iROCK, we get to
one
learn a
voice.
lot. Yes, Dr. Monica.
Actually, working for the sessions like really adds to our academics also, because we learn and add a lot of things while we work on it. So I just would like to add at this point. Thank you.
Team iQuizzers, anything from your side?
Thank you so much, ma'am. It was a wonderful learning experience, meeting all the oculoplasty heroes again. And thank you, Ritu, ma'am, for accommodating a change in mentor at the last moment. It was lovely. Thank you, ma'am.
Thank you. Dr. The fourth team, we have Team Vision. If you're there, would you want to say anything? Or Dr. Varsha, I can see you on the screen. Yeah, Sonali is there. Yeah.
Hello, ma'am. Good evening, ma'am. Ma'am, actually, I want to thank the UC platform. It was a very good learning platform, ma'am, and we actually got to learn a lot of things. Actually, it's on my first online presentation also, so it was really nice, ma'am. Thank you, ma'am, for providing such.
Dr. Varsha.
Yes, ma'am. Ma'am, first of all, we would really like to thank you all, ma'am, to the organizing team for taking so much of pain and efforts, because we know that how much efforts it would have taken for organizing the whole event. Ma'am, just one doubt, if could be clarified. Like, ma'am, we had one question with keratoconus with eye rubbing, ma'am. Ma'am, can it just go in favor of VKC, ma'am? Just had that doubt.
So that was the point of the any guesses round, that we wanted you to be very sure of your answer and then attempt. Okay, so that is how it is guessing. It's like guessing the personality. You can have multiple answers to a same question, but you have to take that risk. So it was up to you if you want to take. In fact, Dr. Lippi gave you for the Shields cataract because you were still contemplating. Had I been the quiz master, I would have given you a minus in that also. You cannot have differentials, or it had to be a very specific answer. So that's why you had to wait for when you were very sure of it. So that was the whole point. Yeah, that's why we kept the negative marking also, because we wanted you to be very sure of your answers and then go ahead with the thing.
Right. Thank you so much, ma'am. Thank you, ma'am.
So the last team, Dr. I think, yeah. So I think with this, we come to the end of the session, and I must congratulate the moderator team Dr. Ritu, Dr. Priya, Dr. Lippy for a fantastic job. Dr. Samita could not be there throughout the session, but she gave her, full support from back end. And thank you so much. Thank you to the entire YOSI Governing Council, Dr. Devakan, Dr. Nilesh, Dr. Prasanna, Dr. Aditya, Dr. Sonal, Dr. Karan for giving their unwavering support, especially Dr. Devakant, for brainchilding this, being the brainchild behind this thing and giving us all of us the opportunity to have this event. And thank you to Numerotech for, tolerating our long sessions every Sunday. Manjula ji is there with us throughout, giving us all the technical backup. So thank you, Numerotech team. So with this, let's call it a wrap. And I really hope to see all of you at YOSICon, irrespective of whether you make it to the finals or not. As Dr. Devakant also mentioned that we are planning a lot of activities, for all of you, those who have been a part of iROCK. And if you could just respond to the poll that he's put up on the group, we can sort of plan it better for you. So it's going to be fun, and not just academics. Trust me, it's going to be fun and a lot of forging friendships. So if you've not registered for YOSICon, do at the earliest, and we'll definitely try to accommodate you in some sessions. It's going to be a very good platform for you all. So with this, I'll request Manjula ji to please end the live streaming. Yeah.
One second.
Yes.